Professor Paul Raman, Professor Carlos Sancineto, and our national faculties. So without wasting much time, I am just handing over this platform to our Professor Bisway sir to introduce our faculty so that we can discuss the topics, sir. Thank you, sir. Bisway sir.
Yeah. Yeah. Good afternoon, good evening, everybody. We have got a galaxy of faculties today. First is Professor Dr. Paul Maria Romans. He was also there. He was the star faculty last time. He has completed his medical studies in the Catholic University of Leuven, Department of Kulak and Leuven. He is a training in general surgery in surgical clinic of University Hospitals of Catholic University of Leuven. He was the director of the Department of Orthopaedics and Traumatology at the University Medical Center of Johannes Gutenberg, University of Mainz, Germany from 2013 to till date. He was the founder and first president of the Belgium Kuncha Society. Was the president of European Society of Trauma and Emergency Surgery from 2009 to 2010. He was the Secretary General of the European Society of the Trauma and Emergency Surgery from 2011 to 2017. Was a member of Pelvic Expert Group of the AO Technical Commission from 1999 to 2014. He was AO Trauma Europe Research Chairperson from 2017 to 2020. Was the editor of European Journal of Trauma and Emergency Surgery. He was the author or co-author of more than 500 publications, of which 367 are PubMed listed. The editor and author of 8 monographic books. Next star faculty today is Professor Carlos Sancineto. The professor head of the orthopedics from the hospital de Buenos Aires, chief orthopedic of Argentina Orthopedics and Trauma. Is specialized in orthopedics and traumatology from the Argentine Association of Orthopedics and Traumatology, December 1889. Specialized in orthopedics and traumatology, University of Buenos Aires, December 1993. Then AO Fellowship in Western with Professor Pedro Regazzoni from March to May 1996. With a member of Pelvis Expert Group of the AOSI Foundation since 2001 to 2014. You're the past president DAOLA from 2007 to 2009. Past president AOT 2017 to 18. He is a member of AO Trauma Technical Commission. He has got numerous publications to his credit. As the author in AO Surgery Reference, as the author in the Fracture of the Pelvis and Acetabulum 4th edition 2015, contributor in chapter Malunion and Onion of the Acetabulum. Professor Ramesh Kumar Sen, everybody knows him that his name is almost synonymous with acetabulum in the pelvis. Professor Ramesh Sen is a teacher of teachers. He is right now the vice president of IOA. He is currently working as the senior director and head of the department, Institute of Orthopedic Surgery, Max Hospital, Mohali. Dr. Ramesh Sen has got over 28 years of experience of orthopedic surgery, including 20 years as faculty at PGIMR. He is a visiting professor in Germany and USA, in addition to having been invited as the guest speaker in more than 25 countries. He is the recipient of the highest research award of SARC countries as well as Indian Orthopedic Association. He has been the chairperson of the Research Foundation as well as the vice president of IO at present. He has pioneered the role of stem cell treatment in avascular necrosis disease of the hip joint, and also has got a patent in his name for new pelvic plate for reconstructing the acetabular fractures. Dr. Dhaval Desai is from the Dr. Desai's Orthopedic Center, Surat, with the chair AO Trauma India from 2021 to 2024, with the past president of Gujarat Orthopedic Association, with the senior AO faculty AO Trauma in India, with the education of AO Trauma India from 2014 to 2018. His specialty is faculty education coaching, pelvic acetabular trauma, and orthogeriatric care. Next is Professor Dinesh Kale. He is a professor of orthopedics from Jain Medical College, Belgaum. He has got many publications to his name and more inclined for more academic activities. He has designed sacroiliac and screwdriver for percutaneous sacroiliac joint screw fixation. Vivek Trika, everybody knows him. He is there in most of the academic seminars, symposium, and everything. He's a professor in JP Trauma Center, AIMS, New Delhi. He has got medical and training and experience from AIMS, New Delhi. He has been a faculty at various national and international courses, AO, CCOT, APOA courses in orthopedic trauma. He's a CCOT trauma committee member. He has got over 100 PubMed index publications. His special interests are pelvic acetabular surgery, complex intra-articular fractures, skeletal infection, trauma, and basic research. Next is Dr. Pranav Saha, is a senior consultant director from Department of Orthopedics of Trauma and Hip Surgery, SIMS Hospital, Ahmedabad, where the past president of Ahmedabad Orthopedic Society, is the secretary of the Association of the Pelvic Association. His academic interests are DNB teacher and AO faculty. He has been a PG lecture courses. He is conducting a lot. Next is Dr. Srinivas Kasa. He is a fellow in joint replacement neuro trauma fellow. He is a senior consultant orthopedic surgeon from KIMS Hospital, Hyderabad. He is the secretary of the Twin Cities Orthopedic Society, executive member of Telangana Orthopedic Society Association. He has an AO trauma faculty. His academic interests are DMB teacher, organized various state level and national level conferences in complex trauma, pelvic acetabular trauma, and arthroplasty. And last is our son from Orissa, Dr. Kishore Panda. He is a consultant of Amri Hospitals, Bhubaneswar. He did his MS from SV Medical College, Cuttack from 2012 to 2015. He has got interest in pelvic acetabular surgery. He has done fellowship in pelvic acetabular surgery in 2017 under Professor Ramesh Kumar Sen. Then fellowship in trauma and pelvic acetabular surgery in Germany 2019 under Professor Paul Romans. He has got publications like polar screw in proximality bell fractures and negative pressure wound therapy in compound injury. He is the organizing secretary and convener of this program. Thank you. Thank you all.
So, yes, sir. So, Dinesh sir, please take over, sir. Hello.
Yes.
Yes, sir.
Hello. I now invite Professor Romesh.
Casual. నా పేరు చెప్పమని చెప్పడానికి నా పేరు చెప్పమని చెప్పరా
To hear me?
Yeah. Yes, sir.
Yeah. I now request Professor Romesh to share his PPT.
Okay.
I'm sorry, at my network is a little problem. There are heavy rains here.
Can you see my lecture now?
Yes, sir.
Can you hear me as well? Yeah?
Yes, sir.
Everything fine?
Yes.
Okay. Good afternoon, everybody. My name is Paul Romans. I'm the director of the Department of Trauma and Orthopedic Surgery at the University Medical Center in Mainz, Germany. I have the honor to speak to you about fragility fractures of the pelvis, diagnosis, classification, and management, and show you some of the work we did in our department on this subject. During the last decades, we are confronted with a rapid increase of fragility fractures of the pelvis in our European countries. You see here a publication from the University of Düsseldorf, where they looked at more than 30,000 patients. There was a rapid increase in the fragility fractures starting from the age of 80 onwards, and especially in elderly women. We have the same progress of this incidence in Finland. Here you see a publication from 2015, and in the graphics you see the incidence that is age specific per 100,000 persons for women and for men. The same is true for the Netherlands, where you see an increase between 86 and 2011 from 5.19 to 7.14 per 10,000 population. So we are confronted with a new clinical entity. And what are the characteristics of fragility fractures of the pelvis? They are always due to a low energy trauma. We have weak cortical and very weak cancellous bone in these patients. The fracture patterns reflect areas of low bone density. So we have specific fracture morphologies that we do not encounter in the high energy trauma. The ligaments are stronger than the bone and are only affected in chronic cases. The bone fails, so to say, between the intact ligaments. So we have a collapse instead of an explosion. The explosion is seen in the high energy trauma victims. And we, in a minority of cases, we see an increasing instability over time. Here you see a clustered three-dimensional bone density model derived from the CT data of 92 European persons. And if you look at the left drawing, you see persons with a higher bone mineral density, and they only have small islands of alar voids, which is a place where there is no bone anymore, between S1 and S2. If you look at the right drawing, you see the patients with a low bone mineral density, and they show large islands of alar voids where there is no bone anymore, situated in the sacral ala on the left side and on the right side, and sometimes there is a small island as well in the middle of the sacrum, so there can be connection between the left and the right side. And here you see an 89-year-old patient where you can very easily discover these alar voids in the massa lateralis of the sacrum on the left and on the right side. This explains the unique and consistent location of this sacral insufficiency fractures, as described by Lindstrom. Sometimes we see them on one side near to the sacroiliac joint, sometimes on both sides, and also sometimes they are connected with a horizontal additional fracture at the level of S1 or S2. Another specific characteristic is the progress of instability. Here you see the conventional X-ray and 3CT cuts of a pelvis of an 83-year-old female with FFP type 2C fracture. I will come later to the classification. But you see a nearly undisplaced fracture in the front and a nearly undisplaced fracture in the back. So 3 months later, you have the same patient that was treated conservatively with a huge dislocated anterior fracture and now a bilateral dislocated fracture in the back. We retrospectively looked at our own patients during 3 years, and we found a fracture progression in about 14% of the cases that were treated conservatively. For us, these were arguments enough for the development of a new classification system. So we looked back at the CT scans and at the conventional X-rays of 245 patients that were older than 65 years. And we found out that they have consistent and specific fracture locations, but they have a different fracture characteristic and also different amount of instability. We use CT scan and conventional X-rays, but not MRI, because we think that the bone is the main problem in these fragility fractures more than the soft tissues or the ligaments. So we first take pelvic overviews to rule out any pathology of the hip joint, and then we see the ramus superior and inferior ramus fractures, as you see on the left side of this slide, on the left picture of this slide. 3 months later, you see a fracture progression, and you very nicely can recognize a bilateral displaced fracture in the front and a incomplete fracture of the sacral ala in the back. We not only look at conventional X-rays, but we additionally look at the CT scans. This is an indispensable additional diagnostic tool. And here you see the same patient with a undisplaced fracture. See the left picture, and 3 months later, a displaced and bilateral fracture of the massa lateralis of the sacrum. We should look very carefully at the CT scans and at several reconstructions of the pelvic ring, coronal, sagittal, and oblique reconstructions, so that we can see every small fissure or fracture line and then come to a correct classification. The first criterion of this classification is the degree of instability depending on the localization of the fractures in the pelvic ring. And we distinguish 4 different categories with an increasing instability. The second criterion, which gives the subtypes, is depending on the localization of the fractures, especially in the posterior pelvic ring. The first type is the isolated anterior pelvic ring fracture that can be in the pubic ramus, can also be very near to the symphysis pubis, or exceptionally in the pubis itself, in the symphysis itself. We have a unilateral, which is 1A, and a bilateral pubic ramus fracture, which is 1B. We looked back at 138 patients with such isolated fractures and compared them with the normal population in our state, Rhineland-Palatinate. And we found out that these patients had a higher mortality, a reduced mobility, and a reduced quality of life 1 year after the occurrence of this fracture. So this fracture is not very simple one. It is a serious adverse event for these elderly persons. You see here some graphic of this publication, and you recognize a mortality of 16.7%, whereas for the same age group, there is a mortality of 5.9 in the female and 4.0 in the male population. The second group is the largest group in our classification, and this is the FFP2. These are isolated posterior lesions, 2A, a crush lesion of the sacrum together with an anterior lesion, 2B, and a fracture of the sacrum together with an anterior lesion, 2C. The third group is a displaced fracture, be it in the ilium, 3A, be it in the sacroiliac joint, 3B, or be it in the lateral mass of the sacrum, 3C. And the fourth group, which also contains this H-type fracture, is the bilateral displaced lesion of the pelvic ring. You see 2 fractures through the ilium, which is the 4A type, the H-type fracture 4B, H-type fracture of the sacrum, and the 4C. These are combinations of instabilities on left and right on different places. What are the treatment principles of this FFP? We need an adequate pain management. The treatment should be as less invasive as possible. If we want to operate, we look for restoration of stability, and this is more important than restoration of anatomy, and we try an early mobilization of these patients. So our recommendations for treatment were to treat the FFP1 lesions conservatively, the FFP2 lesions conservatively first. If we do not succeed, we recommend a percutaneous stabilization in these undisplaced lesions. And in the third and the fourth group, we recommend a closed reduction if needed and an internal fixation. Sometimes we need an open reduction and internal fixation. The conservative treatment should start in the hospital with adequate pain management, mobilization of the extremities in bed, sitting and standing at the bedside, and short transfers of the patient inside the patient room. And then after that, walking with a walking frame outside the patient room. This should be possible within 1 week to 10 days. If not, we will repeat the diagnostics and perhaps recommend a percutaneous stabilization. We should take an X-ray control before discharge as a reference picture for later controls. Simultaneously, we should start with anabolic treatment, and there we recommend the parad hormone. If we need an operative treatment, then we recommend to do it as less invasive as possible. So we prefer percutaneous techniques, and I will show you some of the different techniques that are available. The sacroplasty is the insertion of bone cement inside the fracture area, so in the lateral mass of the sacrum. Here you see a 68-year-old female with immobilizing pain, and she presented in the neurosurgical department. There it was the bilateral fractures were treated with bone cement, but if you look 1 week after the sacroplasty with the new CT scan, you see that the cement is only in a correct place on the left side, but is situated in the sacro-iliac joint on the right side. And there is also some extravasation behind the sacrum. And 2 months after the sacroplasty, patient still had severe pain, and we see here the right CT scan of this tree. We see a progress of instability in the back and in the front. So for us, sacroplasty is not the best method of stabilization because there is a high risk of cement leakage, and there is also a risk of fracture progression despite the bone cement in place. So we tend more to insert implants to stabilize the pelvic ring. A very well-known procedure is the iliosacral screw osteosynthesis, which we also use in high energy trauma. This is a 75-year-old female with a failed conservative treatment. You see the complete fracture of the left sacral ala together with a nearly undisplaced fracture in the front. And this patient was treated with 2 long iliosacral screws and a retrograde transpubic screw. There are some publications that give good results with this type of treatment, but we are confronted with a higher incidence of implant loosening. In this case, we think the reason is that there is no stabilization in the front, so there was a still unstable pelvic ring after the iliosacral screw osteosynthesis. Nevertheless, because of the low bone mineral density, you are confronted with a smaller and lower holding power. So one other solution may be to augment your osteosynthesis with bone cement. This is not the same as sacroplasty because the cement is inserted through the cannulated screw and is located in the center of the sacrum, in the strongest part of the sacrum. In the University of Münster, they look back at 640 screw placements and found out that the cement augmented FFP patients showed a 25% reduced stay in hospital and a reduced complication risk. Nevertheless, they had cement-associated complications in 22%, but these were mainly due to leakage, but without correlation to neurological impairment. Another possibility is a trans-iliac internal fixator. So you place a long pedicle screw from the posterior superior iliac spine in the ilium above the acetabulum, and you connect the two screws with a horizontal bar. This is a patient with an FFP4 lesion, so a bilateral lesion of the massa lateralis of the sacrum, together with a horizontal fracture and combined with an anterior instability. This was an older patient with a chronic instability, so she presented months after the trauma, and we decided to perform a trans-iliac internal fixator together with two iliac iliosacral screws, and to perform a bilateral double plate osteosynthesis in the front because of this bone defect due, I go back here, bone defect due to this chronic instability. And this is the situation 3 months post-operatively. The patient is able to walk as good as before now on the last visit. The transsacral positioning bar is another possibility, but there you need a good transsacral corridor in S1, exceptionally in S2. So you use this corridor for the placement of a bar that is 6 millimeter in diameter. It's a threaded bar, and on both sides you insert a washer and nuts, so there is nearly no risk of loosening of this implant and backing out of the bone. This is a example. Such a patient was 77 years old, 2 months of conservative treatment, fracture progression, where in the left side, a displaced fracture of the massa lateralis. In the front, you see on the one leg stands that there is a huge instability of the symphysis pubis as well. And so you see here the treatment in the back with a transsacral positioning bar together with an iliosacral screw and a double plate osteosynthesis in the front. We just published in scientific reports the results of 79 such procedures in our FFP patients, and just you see that we had a 1-year survival of 90%. At 1 year follow-up, 85% of these patients lived at home and 82% were able to walk with or without a walking aid. In the FFP4 lesions with protrusion of the spinopelvic segment or iliosacral segment into the small pelvis, we prefer a spinopelvic or a lumbopelvic fixation. You see the principle here. It is one pedicle screw in L4 or in L5, another pedicle screw above the acetabulum from the posterior inferior iliac spine, and these screws are connected with 2 vertical bars, and you can also interconnect the left and the right side with a horizontal bar. This is a patient that is 72 years old, fall on the buttocks with immobilizing pain. You see in the sagittal CT scan this protrusion of the lumbosacral segment into the small pelvis, and also here we preferred to perform a spinopelvic fixation. You see the instrumentation in the back together with 2 iliosacral screws and 1 retrograde transpubic screw in the front. If you perform an osteosynthesis in the back, you should also look at the instability in the front. And then when there is an instability, close the ring, performing a, so to say, 360-degree stabilization. The type of stabilization is depending on the precise localization of the instability. It can be located at the pubic rami, near to the bone, in the symphysis itself, and in chronic cases, we even have a bone defect. One possibility is an external fixator with supraacetabular screws. For us, this is not the best solution. In this older patient population, there is a low holding power, lack of comfort, and after some weeks, you have a high incidence of print tract infections. So we prefer the retrograde transpubic screws, the plate osteosynthesis, or even the double plate osteosynthesis if you need a long stabilization of a long existing defect and instability. The retrograde transpubic screw, here you see an example of that. We prefer 7.2 millimeter screws, and the tip of the screws would perforate the lateral cortex of the ilium so that you have a better holding power and a very low risk of loosening of the screws. In another work, we looked back at 146 such screws osteosynthesis, and we found out that there is a good healing in high energy, but also in low energy fractures. So we can use it in the fragility fractures as well as in the high energy fractures. It's a reliable method with a low incidence of morbidity. The anterior plate osteosynthesis as an alternative to the retrograde screw osteosynthesis is certainly not a percutaneous procedure. If you need it because the instability is situated very near to the symphysis, you should use small fragment implants without angular stability and choose the longest possible part for the screws as possible. You see here an outlet view, and you recognize that the screws are all nearly 60 millimeter long. Also here we look back at a group of patients from our department, 48 patients with fragility fractures. You see the mean age was 76 years old, and we compared the single plate with the double plate. We recognized a screw loosening in 45%, especially in the superior plate. Not all of these screw loosenings were catastrophic cases, so most of them we could leave it as it is. There was no screw loosening in the anterior plate, but we needed revision surgery in the patients with single plate osteosynthesis, and not any revision was needed in patients with the double plate osteosynthesis. To look at the results, the outcome of the fragility fractures of the pelvis, also a recent article of our retrospective study, 362 patients with FFP2, 3, or 4. That means that they all have a posterior pathology. What we have seen that if we treat the patients operatively, that they have a lower mortality, but they have more hospital complications than the conservative group, and they are longer also in the hospital than in the conservative group. We looked at 3 years, a follow-up of 38 months. And if you look at the patient-reported outcome scores, then there is no difference, significant difference between the conservative and the operative group. Here you see the Kaplan-Meier curves of these 362 patients. The survival is similar depending on the fracture classification, but the survival is not similar depending on the type of therapy. You see on the right side the therapy for all patients, and you see that the conservative patients have a higher mortality. And in the lower row, you see type 2 lesions on the left and type 3 and 4 lesions on the right. And in both, you'll see a significant difference between operation and conservative treatment. So as a conclusion or conclusions, the fragility fractures of the pelvis are a new entity with an increasing frequency. They are not comparable with the high energy trauma of the adolescents and adults. Some fractures, about 15%, we have a fracture progression over time, especially in the conservative group. The new classification system looks at the specific characteristics of these geriatric fractures. The first criterion of the classification system is the degree of instability, and the second criterion is the localization of the instability in the posterior and the anterior pelvic ring. The treatment should be as less invasive as possible, and you have seen different alternatives for surgical stabilization. Most of them are percutaneous techniques or minimal invasive techniques. Also for the anterior pelvic ring, we can use the retrograde transpubic screw in most cases. So we have to look at the best solution for each individual problem and each individual patient. I thank you very much for your attention. You can find it in the book that we published with Sprinkle in the GBGS. Thank you very much for your attention.
Thank you, Professor Rommels. It was indeed a beautiful article we came to see, because we normally in India get very late presentations. What is your experience in late presentation? 3 weeks, 4 weeks, 5 weeks down the line?
Yes. Then if you see chronic cases, they can be more complicated to treat than the acute cases where you have fresh fractures and is sufficient. In the chronic cases with the huge instability and bilateral lesions, then you need more surgery. Yes, also in the cases,
sir, please go ahead.
Yes, also in the chronic cases, we see that the ligaments in the pelvic ring are still intact. So there is some instability to perform this percutaneous fixation just as in non-displaced lesions. And this is the best for the patients, but because all of these patients are old and fragile, and they come with several comorbidities, so there is a higher operative risk in them.
Yes, sir. Sir, you are asking something.
So, Professor Romans, in FFP type 1 fractures, the conservative management which you told, meaning by relative restriction in the mobility for few days, let's say you told about 10 days or 15 days. Now a process, will these 10 days rest will actually make a difference, because eventually they'll be mobilized again also. So will that 10 days of rest will give us a reasonable assurance that now it will not go further and it will settle down, or it is likely to appear?
Yeah, it's a very good question. I cannot give you precise data, but what we have seen in our retrospective study is that some of these patients show a fracture progression under conservative treatment. So they have another fracture bilateral, they come back and need surgery, but this is a minority. And it is also very important, if you look at these lesions, you know that this patient has osteoporosis. So it is very important also to start a medicament therapy, a drug therapy against the osteoporosis. be it by phosphonates, but the anabolic treatment that we start goes more, let's say, it's more anabolic. So you build new bone as well. And it is effective, but it is not well accepted. It is less well accepted by the patients because you need an injection every day, and it is very expensive.
Yes.
Thank you.
So can I?
For one last question. Yeah, sure. Please go ahead.
Yes. Sir, who are the candidate that we should go for the CT scan at the first visit with the complaint of back pain? So these are then any problem in the spine?
Yeah,
Yeah.
certainly there is in many patients a mixture of pathology and a mixture of symptoms, but you always need a clinical examination together with your diagnostic examinations. So for me, it is relatively easy to distinguish between a sacral fracture and a low lumbar lesion fracture, just because of the localization of the pain. If the patient lays in bed on the back and you go with your hand below the patient, so and you press on the sacrum on the side which is fractured, the patient always will say that he has severe pain. So the localization of the fracture is, for me, a very good indicator where the pathology is. If we do a CT scan of the pelvis, we will include as well the L4 and the L5 region. If there is a pathology higher up, that must be clear in the clinical examination, I think.
So next question to Sen sir. Sir, how often, even with our Indian faculty, sir, how often do we get this fragility fracture in our scenario, or whether we underestimate this fracture or something?
Understand your question?
No, Kishore's question is for Indian faculty for their experience about fragility fractures.
Okay.
Yes.
And I'm just commenting about it that we do see these cases. There are two issues. First, we do not have that kind of a age group still with us where the bone quality is so compromised because our the age, this thing survival is not as high as 90 years, 95 years or like that. But just 4 days back, I had a patient, 88 years old, with the classical things which we can say as FFP4 type injuries. The problem is at that age, the attendants of the patients are not willing to get surgery done. So
okay.
we have patients, probably I may be getting about one patient every month. We don't get very many, but at least 1 month patient every month we do get it. Many of them are not willing for surgery at that stage. They feel their patient is too old to be operated upon. That may be instability, so they tend to take the conservative approach. Now that was my problem, that there is nothing like a conservatively for FFP2, 3 and 4 kind of a fractures. And that makes the situations difficult.
But
yes.
Also in Europe, I would say that this pathology is relatively new. I have looked back at the literature, the PubMed literature on fragility fractures and osteoporotic fracture of the pelvis, and you find the first series in the 1990s. And this series come from geriatric departments. So at that time, there was no publication on surgery of these lesions. It is what we do now is relatively new, and it is not yet proven, scientifically proven, I would say, that this surgical treatment is significantly superior to the conservative treatment. I think on the long run, we will prove that, but the series we have now in the literature are not sufficient to say we should do this surgery every time. My experience now is we get a lot of these patients now from further away, not only from Mainz city, but the region, that especially the chronic cases, so the type 3 and type 4 cases where you have displacement, they ask for surgery because they already had months of pain, months of limited mobility, where they need aid from their relatives or other persons, and they want to find a solution. And some of these patients really ask you to operate them.
Yes.
But this is a changing mentality.
Yes. Sir, when do you decide this trans-iliac bar and bilateral sacroiliac joint fixation? So what is this?
Yeah, we started to do this trans-iliac, transsacral bar fixation.
Yes.
Because of the experience of loosening of the iliosacral screws. And because also we see in a number of these patients bilateral lesions, we think a bridging osteosynthesis is better than two iliosacral screws coming from both sides. So one long bar with nuts compresses these two lesions. It's just perpendicular to the vertical fracture plane. It compresses a little bit and the patient is able to stand and walk immediately on this bar. I would say on this bar. Yeah, and the only condition is that you need a large enough corridor in S1, because otherwise you have the risk of perforation of important structures. So you have to look at your CT scans to reconstruct them, especially the S1 region, and to calculate if the transsacral corridor is large enough. If it is not large enough, and we find, because we did also a study in the ARI in Davos with Asian population, and with CT scans of the Asian population, especially Japanese, and there we have a higher degree of dysplasia of the sacrum, where the corridor is not available. And in this situation, we can do a trans-iliac internal fixation because the bar is then behind the sacrum, but you can connect it, combine it with two iliosacral screws as well. And that gives you an as high stability as the transsacral bar.
One question is intraoperative. In these patients, once you pass the guide wire, do you advise to drill, under drill, or straight away put a screw after you pass a guide wire? Because the bone is so soft, after you drill, probably your screw will just go through.
The highest bone density is the ilium, the cortex of the ilium on both sides, and the middle of the sacrum. And the parts between are very weak. So you have to bridge the weak parts, and to have your implant must be situated in this dense bone. That means the transsacral bar anyway goes through and through, but if you use long screws, they should start on one ilium and they should end on the other ilium in the cortex. And then the risk is low of loosening. That's our opinion. We cannot do.
Should you drill?
Yeah, we start with a lateral view of the sacrum. That's and then we drill with the 2.8 millimeter drill, a very long drill, until the other side, and we leave the drill inside, and we will over drill with the 4.5 millimeter. Then we remove everything, and then we have a canal of 4.5 millimeter, and then we insert the solid bar, which is 6 millimeter, in this canal, always under fluoroscopic control. Okay.
Thank you, sir. I think we'll proceed with the next speaker.
Thank you very much. I will just hear a few minutes at my friend Carlos to hear his voice. And then I will leave you because I have another meeting at 4. Hello, Dr.
Dinesh.
Desai. Hi.
Yes, Dr. Desai.
So I also wanted to ask Professor Romans, the outcome measures of geriatric pelvic and acetabular fractures have a higher incidence of complications,
Sure.
or they are similar to the adults?
They have a higher incidence of complications, but not always related to the surgery itself. It's more the hospital stay, because they are about 2 weeks in the hospital. They get urinary tract infection, they get pneumonia, they get sometimes bed sores, and so on, because they cannot be mobilized very early. And that's the highest risk. In our series, we have a revision rate of about 10%, which is certainly not nothing. But when you look at this patient population, it's very acceptable. So 1 out of 10 patients needs a revision because of a hematoma or even an infection. But this is, yeah, I think the better you know this kind of surgery, which is percutaneous procedure, the lower your complication rate will be.
Sure, thank you.
Please.
So thank you, sir. Can we move to the next talk, sir?
Thank you, Professor Romans. Thank you.
Please, pleasure.
Yes. Carlos, sir, go ahead.
Yeah, one minute, there's a problem. I think I invite Dr. Carlos.
Yes. Good afternoon for all of you. I will ask Professor Romans to stop sharing the screen. If you also
How can I do that? I don't see it. 1 moment.
It should be on top.
Stoppen. Okay, that's good.
Okay,
No, sir.
let's see.
Yeah.
Perfect.
So all the best, Carlos.
Thank you very much, Paul. First of all, I would like to say thank you very much, all of you, for giving me the opportunity to share this presentation. I would like to recognize the superb lecture of Paul Romans. He's so a great teacher and a good friend that I have only words to say that I admire him because of his job and his enthusiasm in pushing hard the knowledge in the pelvic field. And
Thank you.
after saying that, I would like to share some cases and our way of thinking how to resolve the late presentation of instability of the pelvis or pelvic trauma in the adulthood. So the objective of this lecture, first of all, is try to understand the different problems related with delayed fractures, which is the remainder of instability or the amount of the deformity, which are, if you attempt surgical treatment, the forces to counteract, and the role of different approaches and strategies. So the name of the lecture is why to operate and how. And I prefer to distinguish between why or when. So if you analyze the clinical findings of the late presentation, this is not a common universe because it's not the same patient when it is between the 3 weeks and 4 months period or a patient after 4 months. So we have to assume that some cases are presented after 4 months period because they need to walk. And some others are related with the discomfort in the period in between. The fracture is still fresh one, but it's still not united. So we make this distinction according to the principles of Letournel. Letournel used to say that in the pelvic bone, there are 3 different periods. Before 3 weeks, that the bone, the fracture is mobile. In between 3 weeks and 4 months, the fracture is diminishing the amount of movement due to callus formation. And after 4 months, it is not possible to recognize the old fracture lines. because the fracture is already united. So we have to analyze our patient and ask him if he has or her posterior pain or anterior pain of discomfort, gait abnormalities, if there is a leg length discrepancy, and all of them are related with mechanical symptoms. Also, something in between mechanical and non-mechanical are neurological deficit, urological, gastrointestinal, or sexual dysfunction. If those neurological findings are related to instability, you can think that you can resolve or moderate the problems of the patient after a while, but you cannot consider that mechanical problems, if you are properly address them, are going to resolve all the others. So we have to focus in the mechanical problems related to late pelvic presentation. If you go back to the literature, the first report, they used to say the best result about SI joint dislocation and vertical shear fracture. So you know that the bigger the amount of force created a bigger deformity and displacement, the worse result can be expected. So this is the rationale for the surgical treatment from the very beginning of this kind of fracture. However, sometimes we receive the patient on a late presentation. This is not so bad mobile, it's already deformed. And that situation where it used to be relatively easy to resolve when the fresh fracture arrives, it's not the same on late basis. So we need to understand the problem. In order to understand the problem, we need to create our decision-making process. So we need to examine our patient with X-ray, CT scan, and most important in late presentation, dynamic evaluation, and of course, clinical judgment. Paul Roman said that the clinical judgment is crucial to differentiate if it's a lumbar spine problem or sacral fracture problem or SI joint problem. And here it is the same. Without clinical judgment, you must not attempt to do surgery. So it is important to define macro and micro instabilities. Macro instability is clearly evident. You push and pull the hemipelvis, or you internally or externally rotate, and you can distinguish movement where it should be no one. However, micro instability is indirectly recognized by the sclerosis at both sides of the still mobile joint or a still mobile fracture line. So in Paul Roman cases, in the development of the non-union of the sacral fracture, it was possible to recognize these signs of micro instability. And it is also possible to be seen in the cases I'm going to present you. So in the understanding process of the problem, you need to recognize, is this case united or not? It is mobile or not? Is painful or pain-free? So it's a fixed deformity without pain, or it's a fixed deformity with pain? Do I have any chance of exploring objectively the symptoms? That means, am I going to be able to reproduce in the radiological environment a picture that demonstrates what the patient tells me? So this is a 3-month-old fracture in a young individual, relatively young individual, it's a female of 45 years old, and you can see AP view, the severe displacement of the fracture. At 3 months, regularly in someone of 45 years old, the fracture should be united. Just asking the patient to externally rotate the legs in the frog position, you can see how it is the amount of displacement in the direction of the recovery of the pelvic shape. In the reverse, if you push at the level of the graded trochanter, you can see how it increases the amount of displacement. So she was asked to remain in bed for conservative treatment with a fracture pattern that should be treated surgically from the very beginning. And this happened with this another guy. He suffered bilateral SI joint dislocation, and he came to me with the picture presentation on the top, and I remarked the edges of the pubis symphysis of both sides, pubic body of both sides, and I asked the patient to be standing in one leg down on my left, and you can see the body of the pubis was level, and standing in the opposite leg, and you can see the décalage was increased almost twice. That means the pelvis was mobile where it shouldn't be mobile. So if you recognize that, it is very easy to think that the main quality of the pelvic ring is to be stable. And this one, as the previous one, both of them are unstable. The first one at 3 months, this one at 1 year and a half. So instability is not the condition of the pelvis and should be the main idea for the pelvic surgeon to regain 360 degrees of stability about the pelvis. And this was done, in this case, leveling the pubis, and I decided not to create too much trouble for me at the back. So I have done a tension band plating. It's very old case. Probably today I would try to improve the quality of the reduction of the back. I'm going to show you that because what I'm showing you is the evolution of my way of thinking. And this is in the direction of how I did my own evolution. This is a case referred to as 3 weeks after trauma. She was infected, open pelvic fracture with multiple skin lesion, a right colostomy. So I decided to treat her with certain amount of traction and external fixation and percutaneous screwing because it was impossible due to the infection of the skin and the right colostomy to perform an ilioinguinal approach. And this is the end result. It's not so bad. It looks much nicer at the very beginning. However, when she came to me, she was complaining of limping, left groin pain due to the non-union of the front, sacral pain because the sacral fracture was still ununited. But much more dramatically for me, she said, hey doc, when I'm sitting, I move into the direction of the right side and it's painful on my low back. Okay, so is she telling me the truth? That was my question. I questioned to myself. If she's telling me the truth, how am I going to demonstrate why she is painful? So, and I tried to understand the problem of sitting imbalance situation because I was sure that she had a sitting imbalance. Sitting imbalance is the proximal migration of one hemipelvis related to the elevation of the ischial tuberosity with asymmetric weight bearing while sitting. That results in a pelvic obliquity in the coronal plane with a lateralization of the trunk, with a compensatory pseudoscoliosis, muscle fatigue, and dorsal-lumbar pain that progressively increases in relation to the time the patient remains seated. That was exactly my patient's symptoms. Okay, so now I have a literature which is providing me some arguments, but still these arguments were not enough to propose a surgery. So I went back to some other books and said, how is the weight distributed standing and sitting? And you can see those pictures. And you can see that while we are sitting, the leg discrepancy, it is not possible to be equilibrated while we are standing, because if the inequality of 1.2 centimeters standing can be easily be compensated by the body itself. But when the inequality is 1.5 centimeters or more, while sitting, it is not possible to be compensated because you have the same amount of deformity with less amount of or length of bone to compensate that. So those patients who have a difference in height in ischial tuberosity 1 centimeter or more, they are experiencing certain amount of malalignment of the lumbar spine and pain. So, and you can see this is the situation. You can see a cranial migration of the hemipelvis. She hit in this position. And I was drawing the lumbar spine and and both iliac crest and then the remaining spine. And you can see the deformity created by the patient when she was sitting, which was associated with the leg length discrepancy. So how to evaluate that? So I went back to my pelvic model, the plastic one, and said, look, I need to check the different height of the pelvis. So I decided to remove from my radiological field both femora, and we developed this film that we did publish last year, the last update of our work, with its positioning. So this is a professional model in the sitting imbalance X-ray position. So you can see there are no femur covering the ischial tuberosity, and you can a long film to understand the position of the lumbar and of the spine. And this is our patient. While she's sitting, she was tilting on the right direction. And in the other picture, I put a lift under the ischial tuberosity equivalent to the pillow she was bringing. And then I was able to balance the lumbar spine. So I decided, okay, now I have a tool to understand the amount of displacement and the amount of correction I need. So I decided to perform, you can say, a relatively rare procedure. So I thought, she suffered a Malgame fracture in one side. She is ununited in the sacrum, ununited in the anterior component of the opposite hemipelvis. So what I'm going to try to find a surgical strategy to resolve the different height of ischial tuberosities and the non-union of the anterior component of the pelvis. So I decided to create a surgical Malgame fracture. This is how. And you can see this. I have done an New England approach. The green dot line is my osteotomy, and the red dot line is the equivalent of the Salter osteotomy, which is the other possibility to mobilize one hemipelvis. You enlarge hemipelvis by the Salter osteotomy, or you short the hemipelvis by a vertical green line osteotomy. So after doing that, I pulled the left hemipelvis. When I did arrive to the height I consider was okay, I put a long screw along the safe corridor for the AP screws. Then I use it as a pivot. I did rotate along this, and then I fix everything and bone graft every fracture line. And this is the end result. It is not perfect, but now the spine is balanced. So I said, okay, maybe this is the way to resolve this kind of situation. And with this idea in mind, I went to some other cases. But this is another case. 14 months after trauma, with lengthening, leg length discrepancy and sitting imbalance. So my plan was, I was able to make a shortening of one hemipelvis, but this case is 6 centimeters, or almost 6 centimeters different in height. And my shortening, I know that it's not possible to be done more than 3 because of the traction on the sciatic nerve at the greater sciatic nerve. So I decided I'm going to cut one hemipelvis and make a lengthening of this hemipelvis by skeletal traction, and then I'm going to do the shortening of the other one, 3 centimeters of lengthening, 3 centimeters of shortening, so she's going to finish equalized. So in order to perform the release of the pelvis and the lengthening, you need to release everything which is already short. That means the posterior ligament. So you need to cut the ligament from the sacrum like this black line. But first of all, you need to develop a safe flap of gluteus maximus. Otherwise, everything is going to get into disaster. So this is the safe flap in the cadaver model of the gluteus maximus flap. You attach a gluteus maximum from the iliac crest like this, when you finish the posterior inferior iliac span, you go to the midline, detach the gluteus maximus from the processus spinatus of the sacrum. When you arrive to the end of sacrum, the beginning of the coccyx, where you can recognize that the gluteus maximus fiber are horizontal, you go to laterally and you mobilize the flap, and then you can see the sacrotuberous and sacrospinal ligament. This is the model, again, to know how to the drawing, and this is a surgical case. Sometimes the gluteus maximus is not so thin, sometimes it's very thick. It depends on the size of the muscle of the patient, but you can go into the sacrum and detach everything. And you can go further proximally and release the iliolumbar ligament, and sometimes the muscle of the posterior iliac crest. After doing that and cutting the already united bone, then your pelvis is going to start to be mobile. However, not always being mobile means that you are going to be able to reduce it. Sometimes what I do is, if the mobile pelvis is not perfectly reduced, I put the close everything, put the patient in a skeletal traction, send the patient to the ward, and after 1 week or 10 days, I came back to the OR for the definitive fixation. That was my plan for this lady. You can see the CT scan. She had a very tight and united fracture on the back. The sitting imbalance, even with a 4 centimeter lift, she is not perfectly compensated. So my plan was anterior percutaneous osteotomy of both iliopubic and ilischial rami, posterior side joint approach and complete release of both sacrospinous and sacrotuberal ligament, osteotomy, wound closing, skeletal traction, ward control, anti-adequate lengthening of 3 centimeters approximately. 2 weeks later, linear approach and contralateral shortening osteotomy, like in the previous case. So this is my strategy for the lengthening. And if you can see the opening of the hip joints, I decided too much traction. When it happens, I put another pin supraacetabular and continue with the traction. But you can see how doing this, the right hemipelvis was descending. And then on top, you can see how it was originally. And on the bottom, the amount of correction I gained. I was able to gain 4.5 centimeters. And that means more than I was expecting to have. And after doing that, I decided not to perform the contralateral malgain osteotomy because both ischial tuberosity were on the limit, and because she was a little bit fat buttocks, that means that she was able to moderately compensate, so I decided not to be so aggressive. And this is the previous sitting imbalance situation, and this is the correction. And in the immediate post-op, you can see how the remaining of the sacrum already fracture was high, and the descending of the lateral osteotomy. And this is after 1 year when the spine was compensating and the correction of the original deformity and the end result. This is not perfect. She had a deformity, and I did create a deformity, a different one, but it was the compensatory deformity, but the perfection, it's all possible if the patient has no fracture at all. This is another situation. If you take a careful look at this young individual, he was referred to us after 60 days. It looks like a both column fracture, but in fact, it's not a both column fracture of the acetabulum because the fracture of the ilion is overlapped, but you can see the amount of cranial migration. He was sent to his health for conservative treatment. Unbelievable. And you can see the outlet view and different views, and you can see the CT scan. So I was planning to perform exactly the same kind of treatment, so the release of the sacrum, sacrotuberous and sacrospinal ligament from the sacrum. However, he had a sore lesion there, a pressure lesion. So it was impossible to perform the approach where originally was described by Letourneur. So I was thinking how to release the ligament. So for the ligament should be the same, I said to myself, to release them from the sacrum or to release them from the ilium. So I decided to perform a limited Coker-Langenbeck approach. So I reached the ischial tuberosity, I released the ligament from the iliacus, and that is and after closing that, I turned the patient, I performed the ilioinguinal approach, and this is the kind of the reconstruction it was possible to be done. And this is the resolution of the sitting imbalance situation and the equalization of height of both hip joints. So different strategy when the soft tissue from the original approach are not allowing you to do that, always you can find a way to do your release. This is a very sad situation. No doubt, she can be treated by conservative treatment. No, of course not. She can be treated with minimally invasive surgery. Maybe yes. But open reduction of internal fixation, for sure. That was the thinking of one of the surgeons who did treat her in the northern part of my country. She's not so bad, but we can improve it. However, that was not sure. This is a result of a very bad open reduction and internal fixation. She arrived to us after 3 months with a resolution of the immediate post-op infection. So we decided to analyze the deformity. And the description of the deformity, she has a cranial migration of the left hemipelvis, external rotation of the right hemipelvis, and internal rotation of the left. In addition, she has a severe sitting imbalance. You can see the deformity of the lumbar spine with the lift compensating the different height of both ischial tuberosities. So we decided to perform the surgery on her. These are different approaches. You can see where she was infected. So we took the angiogram, and one of the reasons of the bad situation here, she has no gluteal superiority, was done during the surgical procedure. So step by step, we try to reproduce the fracture lines. So first, the release, removing everything which is avoiding us to have a mobile hemipelvis. And after the release of the left hemipelvis, we put her in skeletal traction. You can see here the supraacetabular pin in order to have a very strong skeletal traction. And then we put her in traction. This is it's a wooden table. You know that Argentina is a developing country. Sometimes we don't have resources for investing in very sophisticated table. But if you consider that one of the primitive members of our species was Homo faber, orthopedic surgeon is also Homo faber, the man who makes. So with the pieces of the X-fix, you can develop a good skeletal traction system. We fix the patient to the table in the opposite side, and we put a shunt pin in the first S1 body, and then gradually with the X-fix, you can see in place, we did the rotation of the hemipelvis, and we finished with this kind of contraction for the right side. So now we have a derotation of the right hemipelvis. We perform an osteotomy here. We fix the osteotomy, we fix the front, but still we need to fix the left. We sent the patient for the recovery, and we took the CT scan, and we had a gap in the back. So we decided to use the fibular graft for bone grafting of the back anteriorly and posteriorly. We put SI joint screws, and we put in a spinopelvic instrumentation, and we arrived to this kind of reconstruction, which is not perfect, but it is possible. And this is the evolution of this reconstruction. And she has a balanced sitting, and it is much nicer than the original situation, but it was too much surgery that could be avoided with a very good primary surgery. With the time, we recognized that some of the problems we did face in our reconstruction is due to the lack of proper understanding of the situation. Because several times you receive a patient like this one, you say, she's not so bad. look the height of the hip joints. But she was complaining of low back pain and sitting imbalance condition. So how to improve our accuracy in the diagnosis? Well, we have three-dimensional CT scan. Of course we have it, but we took it, and then for me, it is more or less the same. I know there is a deformity. I know the deformity is in several planes, but the CT scan is not telling me where to go. It's just one helper, but it's much more useful to understand the problem. So with very simple lines, we can understand the problem much nicer. So this is our theme, 3 lines. In this case, one vertical, it should be aligned with the lumbar spine. And I say, okay, the lumbar spine is not aligned with this red line. Second line parallel to the ischial tuberosity, third line parallel or tangential to the iliac crest. This pelvis is tilted because this is a position in the X-ray field, but it's not the real relation between the pelvis and the spine. So it should be corrected. It should be rotated. So this is the correction, very simple. You don't need nothing, and you don't need anything sophisticated. It's just your analysis. And I put this yellow line, this is on top of S1. Now, it is much easier for me to classify the deformity or categorize the deformity. She has a right hemipelvis, which is higher than the opposite one. It is with no bad rotation of the lumbar spine. There is a rotation of the pelvis symphysis because one hemipelvis seems to be an obturator view, the other one is closer to the alar view. So, and we can reproduce them. And if you do that, you can recognize the amount of deformity it was missing in your previous analysis. And again, with the outlet view, you correct inlet view, and also you can put this yellow line to recognize how is positioned one hip joint in relation to the other one. Because many of these patients, in order to compensate the retroposition of one hemipelvis in relation with the other, that create conditions for impingement of the femoral head, they walk with the progression of one hemipelvis in order to have both hip joints at the same level. And this is interesting because you can distinguish that if you properly analyze the patient while walking. If you have a gait analyzing machine, much nicer. And then the spine, because she was positioned like this, and this is the reason she was limping and she was painful standing or walking, but also sitting. And you can see, according to this line, which is the problem. Then I went to my sitting imbalance projection. This is the normal professional model. And this is our patient. And this is the correlation. And you can see, like this, the difference in parallelism in between the ischial tuberosity line, the S1 line, the lumbar spine line, and the pubis symphysis line. These are the corrections we need to recreate. Now, for me, it's much nicer because I don't have a CT scan in my OR. I have C-arm. With the C-arm, I can reproduce more or less these lines, but I cannot check the whole pelvic deformity if I was able to correct it properly or not. And this is the sitting imbalance and the correction of the sitting imbalance with a tilt. So our patient with a correction of the leg discriminant with a tilt, which is more or less the same amount, because she has a little trap. She has a little bit shorter leg. So the sequence is like I showed you before, with osteotomies, and then osteotomy of the pubis, osteotomy of the back. This is my chisel. I did the osteotomy of one hemipelvis. It was mobile. Check in different projection. Now it's a little bit much better. I'm going to show you another trick. This is how I fix my patient to the surgical table. Now I can create a strong traction on the opposite side because she's not going to be displaced by the traction. Then I perform osteotomy the opposite side, open the osteotomy, rotate the hemipelvis, fix the front, fix the osteotomy, fix the previous osteotomy. I was happy with this kind of resolution, and I was ready to put the patient in the prone position. Everything was done in the supine, but the anesthesiology, too much time, we need to stop. Okay, I said, it's not so bad. My reconstruction is rather good. I have this kind of situation. I scheduled the patient for, that was Friday night, for next Monday to finish with a already recovered patient. So I took X-ray to recognize if I was able or not to correct. It wasn't so bad. It's much nicer. However, there is still a different height. And I was going to do the posterior fixation. So with this situation in mind, I took the CT scan. So on Monday afternoon, I went back to the OR, and then I caudally mobilized the remaining of the hemipelvis. I tried to recover the final position. I did improve a little bit. Now we have this situation. Now ischial tuberosities and iliac crest are more or less at the same level in all different projections, but still there is certain amount of posterior migration of the right hemipelvis, and this is due my lack of comprehension of the adequate maneuver, probably. And the other reason, she suffered a fracture when she was 8 years old, and in those patients who suffer a fracture while they're remaining of growing of the hemipelvis, probably at the end, the hemipelvis is going to be shorter than the other one. So full weight bearing with the correction of the deformity. And this is with the evolution. And this is 1 year of follow-up. Everything has already healed. This is, again, it's not a perfect situation, but it's a level situation. She now is with moderate pain. I cannot say pain-free, but she is not using a pillow. She has no sitting imbalance, and the pain is related with the plate on the iliac crest. Conclusion, this is a difficult surgery. Training is very demanding. Adequate results are expectable, but remember, mechanical problems and solution can be addressed. Neurological problems, sexual disorders, gastrointestinal problems remain unsolved or should be addressed by some specialist, and they are part of the bad results when you study this patient. If you put away the no mechanical problems, the mechanical solution is very attractive and it is possible to be done. Thank you very much for your attention.
Thank you, Dr. Carlos. It was just amazing. Just to see how you have interpreted that with simple lines. The only word I can say, it was an amazing talk.
Thank you very much.
So any question, Pranab sir?
No, I was just going to say the same words that Dr. Dinesh Kale was saying. We were mesmerized by this talk. And it seems that there is so much more to be learned in pelvis after hearing Dr. Carlos's talk. So I think we'll have to call him to India, and we'll have to keep him here for a few months.
Okay.
We will get plenty of such cases.
It's a deal.
We will get plenty of such cases.
Can I ask one question, please?
Yeah, sure, please.
Yeah, Carlos, that was excellent as always. And it always gives us a stimulus to learn more and more in pelvis whenever we feel that we have attained a height in pelvis fractures. And thanks for your article, which we published in JCOT. That's also very helpful for us to understand the ischial weight tuberosities discrepancies. How do you decide in your cases of delayed? We have tried on around 5 to 8 cases I have done of malunions around 6 weeks to roughly 3 months. How do you decide which patient requires soft tissue releases, and which one can be just done with bony procedures, or all patients of malunion require releases of the ligaments first, traction for few weeks or so, and then subsequently a second surgery where you can do bony procedures?
Okay, it's an excellent question. If you have a rotational deformity, you can go without inconvenience with the restoration of the anatomy, because ligaments are a problem when you have a vertical migration, a cranial migration.
Right.
Because we were taught that the ligaments of the pelvic floor were to avoid certain vertical movement. In reality, what I learned from experience and from my surgical cases and some anatomical dissection, that once the cranial migration has already happened, the pelvic floor is retracted. So even if you cut the bone and you try to reposition it due to the retraction of the pelvic floor, you can finish. I don't have, excuse me, I have a pelvic model here.
Sure.
Sorry. Okay, can you see this?
Yeah, sure.
Okay. Suppose you have your ligament like this, and this hemipelvis is high. So when it's high, this distance is shorter. Okay. So if you cut the bone and try to recover high, maybe you're going to recover the hemipelvic crest, but while you're moving down the hemipelvis, the ischial tuberosity goes to the center, because the tension here is creating conditions in order not to properly mobilize the hemipelvis. So for that reason, you need to cut the ligaments. You cut the ligament, you release. You have to detach completely the hemipelvis from the sacrum, and that is only possible if you cut the bone and release the ligament. There are few cases where you can mobilize in first step. In my experience, sometimes you improve just by pulling during the surgery, but it's not enough, because you have already released the bone or cut the bone, release the ligament, but still you have psoas muscle, abdominal muscle, spinal muscle, they are short. So by pulling, by traction gradually, this muscle can be mobilized, and with limited risk on the neurological structure, because the patient is awake and is telling you what happened. You can control the foot movement. Okay, you say, no, we are a rich country, we have potential evoked, and we can check that. Yes, of course. Sometimes when you mobilize in one step and the evoked potential tells you, hey, something is happening, you don't know really what is going on, because we are using this for a spinal surgery. Usually they tell you, the neurologists tell you that something is wrong, and you haven't finished your correction. So in my experience is, okay, I do not hesitate to put the patient in skeletal traction, which is the original treatment for the amalgam fracture. So those cases I can resolve with moderate traction on first step. Okay, if I cannot do it, skeletal traction, gradually increasing the weight, and for sure you can improve the quality of your fixation. The day of definitive fixation, I do the surgery under the skeletal traction. So my clamps are just approaching the pieces of bone, or I do a screw fixation, a screw reduction, but the reduction is not by the clamps. The reduction is by the traction. The gross. And then when you align your fragment, it's easy because your vector is smaller. Otherwise, you have to create strong force. There is no clamp. You don't have where to clamp to properly descend one hemipelvis. You need the ejection of the traction. And of course, as any other procedure, when you need to open and close, the infection rate rises. Because you open, the patient is lying on the surgical approach, and you are going to open it again. So I do not use stitches. I use intradermic suture. I mean, nothing in touch. I cannot see the suture or nothing. And then crossing fingers.
Okay, thank you. Thank you.
A
Very
question
welcome.
from my side. When we are doing this kind of a lengthening to a proximally shifted, we understand that if it is a relatively a fresh injury, the neurovascular structures have actually shifted up. So the safety limit of 2 centimeters or whatever we can say can still be longer because of the proximal shifting we do have a play. But in a long-standing deformity, let's say a year or 2 years or 3 years, there is a sufficient contracture formation, and in that stage, a kind of a barrier stage that you can't more than 2 centimeters or 2.5 centimeters or maximum 3 centimeters, where your risk of neurovascular surgeries like neurovascular complications likely to be high. So have you done any case in which you have done in stages? First you did about 2 or 3 centimeters, and then you again went subsequently for the second time second time stretching or not, or you have shifted to the other side to correct?
That's right.
Okay. I have a short answer to a very good or excellent question, or I can develop a longer one. My first correction was the conventional one. I have done the approach proposed by Letournel. I reduced everything and was able to reduce everything. But it was only 1 month old, so it was in the period, the second period of Letournel. That was very easy. So that almost acute. This is not a late referral, at least in Latin American countries or developing countries. Maybe it is the same in India. You cannot say 1 month or 60 days is a late referral. But if you go to the United States or Europe, for them 2 weeks is a late referral. I've been discussing with English surgeons saying, no, after 3 weeks, you cannot attend surgery. Look, all my cases are coming after 3 weeks.
Yes.
Okay, so this is something between friends. We are in the part of the world which is impossible. We need to manage with it.
Yes.
Second issue, when the fracture is already healed and everything is retracted, it is extremely difficult to mobilize. That means after 4 months, after 1 year, after 5 years. The last case I did show you, it was after 8 years. So it's a long time. However, you have to understand the spirit of the soul of your lesion. I thought that, and I think that it's easier to shorten one hemipelvis than to enlarge the opposite one. The problem is you are going to be the shortening the one hemipelvis which is healed, sound, which has no real problems. So this is a very strong medical legal argument if you fail. Because everyone is going to accept a complication in the already injured side. No one is going to accept happily a complication in the healed side. In this case, I show you, I have done the shortening because it was ununited in the front and she was symptomatic in the front. So I needed to fix the front anyway. And the sacrum was ununited in the back. So I didn't want to create too much pressure on the sacrum by doing the lengthening. You have to remember that was one of my primitive cases. So the rationality for me was the shortening is part of the treatment of the non-union of the front. And she had the right colostomy. So I was working in the left hemipelvis. That was a very safe area for the surgeon. But for sure, the shortening is a very good idea. Because the shortening of 2-3 centimeters is nothing for the architecture of the pelvis, and you can do it almost percutaneously. When you recognize which is the safe corridor for the osteotomy, you mobilize the hemipelvis already osteotomized, and then you can put just percutaneous screw, and it is going to be a big bone-to-bone situation. Step procedures are going to be performed in my place when after a complete release, you are pulling and nothing is happening, or very little is happening. You put the lamina spreader and you can open it widely, but when you pull, nothing is happening. The other problem is that you do your release in the prone position. Where the patient is prone, the release hemipelvis is going back because of the body weight. It's a problem of Mr. Newton, the gravity. But if you turn the patient, you put in a supine, the gravity is working in your favor, not against you. So my rationality is, if I cannot do it easily in one step, I release everything, put the patient in traction. Sometimes with the first step, I can gain 2 centimeters, but I need to gain 4 or 5. So I put, if I have any complication, what I gain, I screw it and go to some other place, because sometimes those patients are bleeding a lot. And if you don't have a good anesthesiologist, it's better to preserve the patient for step by step. That happened to my last case. So, and then when I put the patient supine, I can fix the patient properly to the table. The procedure can be longer. The anesthesiologist feels much more happier because it can control the airway easily. The traction can be done in a proper way. Gravity is my favor. And then I can use percutaneous screwing for the long SI joint osteotomy. And I can pull in an oblique vector to the ceiling of the OR, and then I can gain adequate reduction without a second big approach. And if I need to increase the stability of my assembly, I turn the patient prone again and I put the tension banding or spinopelvic instrumentation. I'm not so sure if this is a very long question to an excellent, a very long answer to an excellent question, but this is our way of thinking. And for sure, Ramé, there is no Bible, there is no Quran, there is no religious book that tell you this is the first amendment, commitment, and this is, no, there are no fixed rule. Fixed point where it should be released, and you are like, my personal training was done not with any mentor, it was done with my patients. So it's like this, you are walking along a very long tunnel, blinded and touching the walls, and discovering the end just many times by coincidence, by analysis.
What we found it out that when we have sent a patient on traction after doing the initial release, at the time we could see that we could have a release, but subsequently after that traction which is given by the patient at his home or maybe at his place at 2 weeks, 3 weeks, still we do not get that kind of an effect. So that was one problem we found with that traction, release and send. If we are making that traction within the hospital setup is a different thing, where it is controlled. My another question is that if there is a problem at the sacroiliac joint which is disrupted and probably painful also, maybe after a year, I am again talking about, as you rightly said it, our delay is more than a year or something. So at that stage, will you go through for the release through the same sacroiliac joint, or will you still search a safer area laterally?
Either way, what I do not recommend is go to the old fracture line of the sacrum. I've done it only once. It was okay for the release, but after and put the patient in traction, but the day of the fixation, I increase the traction and I damage L5. But if you have a SI joint, you can cut along the SI joint without any trouble. If you have a sacral fracture, I go parallel to the SI joint and I create an osteotomy parallel to the SI joint. It is much nicer because the SI joint is this size, 1.5 centimeters lateral to the SI joint, you have this surface area of contact. So my rationality is, I have a sacral fracture which is elevated. If I cut the SI joint, which is fixed, and I try to reduce the hemipelvis, I will finish without bony contact. In the reverse, if I cut parallel to the SI joint. And you can see can you see here?
Yes.
The amount of contact is limited, but if you cut here,
Just a
the amount of contact, can you see?
Just make it little up. We are not able to see it. Yes. Now we are able to see it. Yes.
If you cut here,
okay,
from the back, if you go here, the amount of contact is limited, even in a good situation. But if you cut here, look at the amount of.
Please hold the model. Yeah, that's it. That's it.
Because I cannot see my own. But if you cut here, the amount of contact is maximum. So you can descend the hemipelvis, you can forward the hemipelvis, and still you're going to finish with contact. That's the reason you can fix it with SI joint screws, because you have extremely good bony contact.
But what about non-unions?
Non-union of malunion of the sacrum.
No, non-union. You have a non-union overriding and the fracture is not yet breached. Now will you go through the same fracture or you will still go parallel?
If I have a non-union of the sacrum, I do the same, because what I need to increase even the healing rate, and the healing rate even of the non-union of the sacrum is by compression. So I cut the ilium, mobilize the hemipelvis, align the hemipelvis, and then fix through the osteotomy, through the non-union, go into S1. I do not touch the non-union of the sacrum, because if you want to release the non-union, you are going to be risking your roots. At the end, your sacrum is going to be like this. But it doesn't matter. If it is already healed, you are not running a marathon for the anatomical reconstruction of every detail. Your marathon is to gain stability, 360 stability. So if the hips are in proper position, the ischial tuberosity are in proper position, the iliac crest in proper position, who cares what happened in between? It's like a diaphyseal fracture. If you are going to use conventional plating, you need anatomical reduction. If you're going to do bridge plating, MIPO technique, you need a bridge. If you're going to use a nail, you're going to be bridging the fracture. Allow Mother Nature to do its work, and you have to do your own work properly.
Okay. I think that clears the point very well.
Yeah, you said you do shortening on the normal side. Exactly, shortening means you do an osteotomy and create a malunion of overriding, or you remove some part of a bone there to create a shortening.
No, when you do a vertical, you think about Malgame fracture. Malgame fracture is a vertical fracture in one part of the pelvis. So by the action of the abdominal muscle, psoas, and everything, the hemipelvis is going upward. So you just make a cut, and then you push the lower leg or the limb, and then with the forceps and the iliac crest, you elevate, and you can see the amount of correction you have created, because you can see in different height of the iliac crest. I said, look, I needed 2 centimeters, 2 centimeters. I need 3, it's 3 centimeters. More than 3 centimeters, if you take a look to can you see the greatest sciatic knot? Because I cut through the greatest sciatic knot. Sometimes can create some tension on the sciatic nerve, and provided it's the uninjured side, it is not nice to have a problem with the sciatic nerve. But 3 centimeters is not a problem at all. At least in the cases I have done. Because if your patient is 1.95 meters, it's not the same if your patient is 143 meters. So 3 centimeters is not a fixed rule, it's related to the size of the patient. But on average person, 3 centimeters of shortening is not a big problem. Then you need to reshape the iliac crest for the reattachment of the muscle, and you can use part of the excess of bone as bone graft, but it works properly.
So, so we can discuss more and more in the case presentation also. So, Kala sir, can we move on to the next talk, because the time
I will invite Srinivas Kasha to
yes,
present his cases.
Because the talk was excellent and the discussion will
I think all of us should clap for that.
Yes.
It was Absolutely an amazing talk.
Yes.
Thank you very much.
Yes.
Yes,
Srinivas sir.
Thank you,
Sorry.
Kale.
Yes.
That was really an amazing, after an amazing talk. So, I have a small question to Dr. Carlos. This is a simple question. You have used a wooden table to which you have fixed your fixator. So do you do surgeries on wooden table? How is that go? How does it go?
This is a real wooden table, because I'm going to tell you. When I did start, there were no good radiolution table available. So I decided to manufacture, and I was in United States. They were using regular table, but they were not able to see the pelvic properly to accurate see. So then I went to Paris, and Letournel was using a traction table, very sophisticated, but it was impossible to buy something like this in Argentina. So when I came back, I said, look, and I remember that the cardiac surgeon, they use a wooden table for the pacemaker position. I said, look, this is the solution. What I need is something like this. I make it narrower for the C-arm to mobilize, because it has nothing in the middle. And then when I tried to buy a Jackson table or something similar, it was $250,000 US. At that time, my wooden table cost me $200. Very simple. If I'm going to invest money, I prefer to buy a C-arm and not a table. But if you are working in a very rich hospital and they are going to provide you everything, you can do it in a carbon. Now we have a fiber carbon table, which is very nice, but I do not attempt to put my shunt screw in this fiber carbon table. I do it for some other procedure, but I'm not going to destroy this table that was very difficult to be bought by the hospital. It's not the Jackson table, but you can understand that.
Great, thanks. So let me just go to the case. This is a 25-year-old male, fell from second floor. And the present, I could not get the X-ray because I'm directly presenting the CT scan. You can make a impression. So clinically, he has got decreased perianal sensations as well as bladder sensation is also lost. 25-year-old male. So let's just make it in some interactive. Kale sir, what could you make? Kale sir.
You're asking me?
Yeah.
There appears to be a sacral fracture that is obvious there. Also, there is some amount of overriding on the, as if you want to draw lines as shown by Carlos.
This is a fresh case.
Yeah, I know, fresh case. But there is also an element of SI involvement on the other side also.
Okay.
The SI opening little bit on the other side, besides the injuries on this side.
Okay. I'll just show you the sections as well.
It's a bilateral sacral fracture.
Always look for lateral sagittal views, CT scans in such fractures, 2D scans. Hello.
Yeah. Sagittal.
Always look at sagittal lateral 2D scans to look at what exactly is the fracture. The 3D scan does not give us. So you can see the spinopelvic fractures and the flexion injury with type 4 or type 3 sort of an injury, Royal Camille. And that is the reason which you need to, and there's, because that's my protocol. That's for the residents I'm saying out here, the people who are learning, that CT scan sagittal view, whenever you see two fracture lines going in the sacrum, always look at the sagittal CT scans 2D, mid sagittal. That is going to tell you whether it's a spinopelvic dissociation or not. Any other CT scan films or views may not give you that proper views, be it 3D, axial, or coronal. Sagittal ones are the ones.
Excellent point, sir. After this sequence, the one which you are asking for.
Yeah. So here you can see the S1, S2. Yeah. S1 is basically usually through S2 that you will have. The perineal sensations will decrease when the S2 fracture is there.
Yeah.
So S1, S2 is going to go, and that has gone posteriorly. It is not complete, but it is partial. So it can be odd type of a classification, 1 or 3, whichever way you look at it. I would go in for a spinopelvic, distract it, reduce it, depending upon an acute fixations. If it is old, you said it's acute, so we can get the distraction by spinopelvic and a triangular osteosynthesis for this. Else, if it is an old, many a times we have done the laminectomies and the sacral decortication of the posterior dorsal cortex, and just given them adequate areas for the spine to have decompressed.
Vivek, the only problem is how do you disengage the
Sir, if you do acute fractures, you go through the S1.
Do you want to explore the card and decompress?
No, that's what I'm saying. In an acute case, you can just go for L5 or L4 spinopelvic with the sacroiliac screws, the S1 sacroiliac screws which you put, which are going into the LC2 corridor. And then with that, once you distract your threads with like you do in a spine fractures, then this S1 and S2 are going to go and distract. The problem happens in reducing them in the flexion type. But once you do that with an acute injury in a prone position, by some pressure, you can easily get that. The problem is in late presentations, which we get, where we might have to do a decortication and just leave it.
No, it will distract, but how will you dehinge that angulation? Because
so that you can do with your, you have the rods and the rod pushers, along with the spine rod pushers, you can first distract it. And if you require, you can also use the lysis sort of a screw if you want, the spondylolysis screws by which you can, how you bring your spondylolysis back to the position, the same way you can bring it here.
But will your spinopelvic distraction distract S1, S2?
Yes, because you are putting the S1, the lower screws which are being put in the sacrum, that is going to help you.
I think we can consider this fracture in such a way that your both iliac crests and the remaining sacrum is one fragment, and your S1, S2 central body and the spine is another fragment. Yes, and you can combine it with lumbopelvic fixation, and that will be able to give you the reduction.
Perfect, perfect. So, any inputs?
If you look at it as a spondyloptesis of a spondylolysis, which is grade 4, it usually goes at L5, S1. Now this has gone at S2, S1, S2 level. Since we cannot go in an S3 and put it and push up the lysis, we use the sacroiliac corridors and in the distal part, and then try to distract them. That's how it can be done. Many a times it will not come if it is below S2, but then you many a times will have to leave it also if it is at the level of S2 or below it.
But here the laminectomy helps.
Yes.
De-roof it.
Yes. If it is done, that's what I said, acute, correct, you can still get it, because as soon as you try to distract, how your spine comes back whenever you are doing a dorsal lumbar spine kyphosis, it just comes back when you distract it and you push in with your rod pushers. The same way it can be done in an acute case. If not, then you will have to decorticate it.
You got that. So, like Dr. Pranav told, both iliac crest and pelvis, along with sacral ala, is as a single unit has moved into flexion, something like this.
Into extension.
It is actually into flexion.
Okay,
yeah. Into flexion, and that has caused, the nerve, card these things, making it, thin. And so I went, in this case, I went dorsally, and decompress that area. And I could get the decompression. I have not reduced it, but fixed it in situ with that.
But how did you fix
Spinopelvic.
spinopelvic? Okay, okay, okay.
And so the patient he was actually from Bihar, who came for work in Telangana, and after COVID he has sent a video. So that's how he walks. He has regained his bladder, regained his bowel sensations. Is doing walking and doing his activities. So the one in conclusion, the point which is already made by Dr. Vivek Thika. So sagittal sections, they give the good kind of information more than the 3D CT scans. When you have something, some kind of a flexion injury or a H kind of a fracture at the sacrum.
In one of the cases, we have used towel clips.
That's it. Thank you.
Both the spinous process and try to pull it back, but we couldn't succeed. Finally, we just decompressed that area. He regained completely. Because I don't have the photographs to put up right now.
That Dr. Kale, the trick is that you do it as early as possible. I have got both the cases. We have done the towel clip method. We have used some sublaminar sort of a wires also to reduce them in the sacrum. And if it is an acute within 5 days or so, it definitely comes back very early and easily. However, as soon as it gets delayed, the inner pelvis, whatever structures are there, they are getting contracted maybe. So you may not get a complete reduction of that. And that's when you might have to do, as you have rightly said, the cortical decortication. Sometimes the full 100%, we have been able to correct 70% of that and bring it to 20 to 30% of overlap, which was fully gone around. So that can be done, requires some dissection, but spinopelvic helps you as soon as you distract it. Most of the things bring it back.
One trick which has been tried was that we use a plate on the either side on the lower fragment, and then with the manipulation and screwing a kind of a, you can say, using a plate as a lever to get that reduction done, and then put the proximal screw over the sacrum only. So distally put the screws, had the reduction, proximally pushed it back to the anatomical position, and we could reduce that deformity also. Obviously, it was after the decompression was done.
Okay. But in this case, sir, the dorsal cortex was intact.
Yes.
It was internally into the spinal canal, it got displaced.
Okay.
So in this case, we need a interconnecting rod, or we don't need a interconnecting rods to both the hemipelvis? So
it's basically it was in the that sagittal plane, it has got deformed, and you have both sides fixation which is angular stable.
Okay.
There is a controversy. There is a controversy regarding the spinopelvic transverse rod fixations. You will find that half of the pelvic or the spinal surgeons say that when you are doing a lumbopelvic fixation, you should put in a transverse rods when you are doing L5 and S1 or L4 and S1. And there are half of them who many a time say that the transverse rods is not adding, rather it is not helpful at all and should not be put. So some people are very vehement in not putting a transverse rod. I do not know the reason, but there is a lot of controversies when you try to do this, the transverse rod fixation.
I think after the fixation, we can check the stability on table itself. And if we find that there is the two rods are not parallel and they are moving, then we can put connecting rods. Otherwise, we may avoid it.
Actually, when it is an older injury, it is better to put it.
Yeah.
In a fresh injuries, because the stability is reasonably achieved, so you may not have it. But in older injuries, we have found it is useful.
Yes, very right, sir. Because what happens when you are distracting in an older injury, what happens is that your hemipelvises, they flare up. They go mediolaterally, they they open up. When you are reducing it vertically or bringing the length back in vertical direction with the distraction on, instead of going vertically, they go at 45-degree angle and it opens up mediolaterally as well. So that's why the triangular osteosynthesis is usually done for iliosacral screws. And it also adds, the transverse rod also ensures that your sacrum does not open up when you are distracting the vertical distraction.
So, Professor Carlos, your input on this transverse rod?
Just
Okay.
have a break for it.
Okay. Okay. So we can move to the next case.
Yeah.
So
I think I'll call Dr. Vivek to come forward.
Can you see the scan? Hello?
Yes, we can.
Okay, fine. So it's a simple case. I've written complex, but it's a simple one. In the sense that we should be, how a standard pelvic injury when it comes to us should be managed. And that's what we would like to discuss. It has got few components on both the sides of pelvis. So that may help us to have a good discussion on both the types of fractures that we see, especially in a pelvis injury. So he was a 40-year-old male who was hit, had some abdominal injuries which were treated conservatively, and was having pain in the pelvis. And this is the X-rays which we had. You can see that he was having a binder on initially, and that's how he was being treated. So I'll just go about, I'll finish it, and then we can have the discussions on various. Just when we, in what next, we normally, and when the patient is stabilized, we get the CT scans done. So this is not as complex as Dr. Carlos or Srinivas has shown. This is a simple acute fracture, a classical usual presentation which we see when we have these sort of fractures. So this was the CT scan, and these are the axial views of both the sides of CT scan. This is a 3D CT scan showing you a complete orientation of how the fracture lines are going. So if I'll just stop here for the people who are listening to this, besides the moderators and the experts out here, how do we classify this? And that's the question, and how we go about managing this fracture. So that should be in our mind. First of all, it will be a very hemorrhagic or acute. We can see it's involving both the hemipelvises. So we should be having a good acute management of such cases. I've broken it down into diagnosis on the right side and diagnosis on the left side for the people who are listening to this, so that let's analyze it properly sequentially. If you see on the right side, there is an SI joint which has got fractured as well as dislocated. You can see a fracture line going in the ilium, which has got the opening on the anterior side of the SI joint, and the fracture line going midway into the ilium. So this, and if you see the axial scans, we can see it is roughly at around halfway, 40% from the anterior side that we are having this sort of a fracture. So these are usually an LC type 2 sort of injuries known as crescent type of injuries. And if you see the right lower 3D scan, you can classically see the crescent or the posterior ilium, which is intact and is in continuation in ligaments with the sacrum. So that gets broken down because of the iliolumbar ligament in a crescent sort of a fashion, and that's why this injury is known as crescent injury. As per Day's classification, this is a classified or by Martin Bircher from UK. So this is type 1 is anterior 1/3, type 2 is intermediate, and type 3 is lower down, very posterior. And based on this sort of an axial scans, we can decide how do we treat these crescent injuries. So that was regarding the right side. And if we just concentrate on the left side, what we see is a SI joint dislocation, but with no fracture, having both opening up of the anterior SI joint and posterior SI joint, both in the axial and the coronal sections, which we can see. So both the anterior and posterior ligaments are broken, which may be a type of APC or an external rotation injury, which has caused one of the hemipelvis to get compressed and the opposite side to go into external rotation. And that's what brings us to the diagnosis, which is an LC3 sort of an injury, which is more complex than LC2, which is not only involving one hemipelvis, it is involving both the hemipelvises. One side is lateral compression and the second side is having an open sort of an injury. Days type 2. So I'll stop here and we can have discussion on how do we go about managing definitive treatment for such fractures. The moderators may please give their analysis and comments.
Sir, is there any vertical component in the
pelvis?
yes.
This is without a traction, so it's not a major. Yes, on the left side, when there is an APC or a complete disruption of the hemipelvis, as we see on the posterior side, both anterior and posterior joints are opened up. There can be a vertical component, but that's how all the type C parts behave when they are opened up completely. The ligaments which Dr. Carlos is breaking in the end after 1 year for the malunion reduction, that's what has happened right now acutely. So it can go up or it can come down as you want it to.
Yes, that is the confusion with this type C and vertical injury, sir. Means
because all type C can have a vertical displacement based on the muscle pulls, because the ligament which is holding them are, I think, not there. So the vertical, the spinal muscles, the erecti and the quadratus lumborum, they can always pull them as there is no stabilizing ligaments which are available. So both vertical shear and APC3 on one side will more or less behave in a similar fashion, depending upon which component of injury was more prominent at the time of impact.
And further, it is a tilted. Pelvis is not a horizontal structure, it is a tilted structure. So whenever there will be disruption in the ligaments, it will automatically move little superior. So that is a natural displacement. It will never be pure posterior. It will be always posterior superior.
Right.
So for planning the treatment, I would want you to answer 3 questions. 1, what is the hemodynamic status of the patient, whether he has been resuscitated? Second, what is the soft tissue condition of the patient? And third, what is the neurological condition of the patient?
The very fact that 3D CT scan has been done, in our hospital, it will only be done when it is hemodynamically stable. So all these things, all the 3 factors are purely under control. There is no issue. This is not a complex case. I'm not making it complex. This is for learning process. I want, because we have got both the sides where we can learn most of the pelvic treatment management in this sort of a fracture. So that's why I put it. There's nothing besides what I'm showing. It is a simple fracture pattern, which is slightly complex in nature.
Yeah, so I think what we have to do here is we have to do a reduction, and that reduction will be mostly assisted with traction and external fixator if required from the front. And once we are able to get some amount of reduction, we will do a iliosacral screw on the left side to get a compression. And we will also do a iliosacral screw on the right side. But at the same time, on right side, we have to be sure that the reduction is good. So we may have to do a limited open reduction to confirm the reduction.
Okay, so that is what brings me, and I would like the experts and all the moderators also to discuss that how do you decide if such a fracture comes, especially the crescent, whether, because crescent, I'll show you later, that can be treated both for prone position as well as supine. And if you really want to control the crescent displacements, It is said that if you go prone and fix it both vertically and horizontally, that is going to help. In such a fracture pattern, what will be your position, sequencing of right side and left side, and positioning of prone or supine in your setup? Because that is the next question which will automatically come for a surgeon.
My stepwise would be, I will handle the right first, prone position, reduce the crescent. Once reduce the crescent with a plate, you can use a calcaneal plate which has got a big hole which can take a sacral screw. I mean, we have used a calcaneal plate in the reverse way, where the big hole that you see in the calcaneal plate, that is the only hole through which you can pass the sacral screw. So this calcaneal plate can reduce the crescent before you pass the screw, because on the left side there is a distraction. So you will have to pass a guide wire transsacral from right to left, reduce the left one and pass a screw then from left to right. If you try to hold the reduction and pass a guide wire from left to right, it is extremely difficult to do that. So you reduce the right, pass a long guide wire from right to left, and then pass a transsacral screw from left to right, which will act as a compression screw.
Okay. Anybody else? Carlos, Dr. Sain, anybody's? Dr. Srinivas, yeah, please.
In
Carlos.
the case of a polytrauma patient, I prefer to treat everything in a supine position.
Yes.
Your patient has a sling, as I recognize by the clamp in the AP view. So this is moderating the amount of displacement. But for sure, both sides of this pelvis are vertically unstable, because the crescent fracture, even if it's coming from a lateral compression mechanism, it has a vertical displacement right now. And the opposite side, the SI joint, has a vertical instability. You can see the transverse process of L5 is already fractured. That means that all the ligaments are torn.
Yes.
So it doesn't matter which is the mechanism of injury. I prefer to consider the anatomy of the fracture, where is the point of instability. And for me, I will start with the left, the SI joint, which is possible to be done by close means, no sure about that, for sure, no doubt about that. If the reduction is not perfect, you can put a shunt pin in the iliac crest and use it like a joystick. If it's not enough, you can put a second shunt pin in the supraacetabular region, and connecting both shunt pin with the bar, you have a wonderful reduction tool. I use it several times because you can derotate in different planes the hemipelvis until you reach a good reduction. Then I fix it with SI joint screw. After finishing that, you can do the same for this crescent fracture. And I have experience in the management of crescent fracture by close reduction and percutaneous fixation. You have big amount of bone in the remaining of the SI joint, in the part of associated just with the ilium and not with the sacrum. But if your screw are going to be at the level of the fracture line, this is not a big problem. What I use is a 3-hole 4.5 recon plate. And if you use 6.5 screws, even 7.0 screws, you can go through the plate and you can use the plate as a reduction tool and as a big washer, and then you put your SI screw through the plate in the conventional way, and usually it is stable enough for avoiding to put the patient in the prone. Sometimes what I use is a long screw that's coming from the front to the back, and this screw goes at the level of the anterior inferior spine, a little bit lateral 2 centimeters, and you can reach from anterior, the posterior aspect of the ilium, and you can check it with the inlet view very nicely, and you can add inlet view plus obturator-like view, and then you can see the trajectory of your K-wire or your drill bit or your screw, and then you can increase the stability by fixing both iliac component. And for the anterior component, if you are able to use retrograde screwing, this is going to be a damage control strategy because the amount of bleeding by doing everything in this way is minimum in a polytrauma patient. If the patient needs much more stability in the front and the patient is hemodynamically stable, I do not hesitate to open through a fan steel approach, and you can call it a stop approach or whatever you want to call it, and you can use a bridging plate from one hemipelvic to the other. But with this fracture pattern, if you have very nice quality of bone in the back and good screw fixation in the back, you can try by screw fixation in the front because the amount of stability, extra amount of stability in the front with good fixation in the back is limited. But for sure, I will try to fix the front also.
Right, right.
If
So
your patient is not as good enough in terms of hemodynamical stability for continuing with surgery, just X-fix in the front or in-fix in the front. But no doubt that on acute basis, you should fix the SI joint in order to avoid further displacement and much more difficult resolution.
Thank you. Thank you for a nice and elaborate way of managing these injuries, because that clears many of the points. Dr. Sen, sir, if you would like to add something.
No, basically, I also feel that I'll be doing it in a supine position. Obviously, left is not likely to give a issue, but on the right side, I'll have an attempt at close reduction. And if I find it is difficult, even by putting a shank pin into the ilium, I'll go with the lateral approach, the standard approach anteriorly, get that reduction properly and put a plate down there and up there. And that will be my simple this thing rather than struggling to get that fixation. So I'll just have that simple thing. And in front, obviously, it could be that we may use a phenostite or we may pass a percutaneous screw fixation.
Right. So I'll just like for the audience to see the C3d Ct scan, because that's what was highlighted by many of the analysts out here. You can see on the left side, the transverse process of L5 is broken. Along with, if you see the sacrospinous on the spine, on the sacrum, you see a bony fragment on the left side again. And that is again showing you on the first 3D CT scan, how the ligaments have ruptured both on the transverse process of L5 and the sacrospinous ligament has got a bony avulsion from the sacrum many a times. So these are subtle points which tells you how the ligaments have broken out, especially in these ligaments of your APC injury or whichever injury, vertical shear, where your ligaments of the hemipelvis are coming. The questions have already been answered regarding the positioning, which was my first question regarding position, management strategy regarding right side or left side. And it depends on your surgical preference, which one you want to push and go ahead first. Positioning, as was said, I think that in my hands also, I normally go supine because most of them are polytrauma patients and they help us in managing these injuries. We managed him initially for the 24 to 48 hours, and then I took him up and fixed all his fractures at one go after managing him with the binders on. So this is what we took him on the supine. I tried to do the right side where the crescent fracture first. And here I reduce it with traction. But as Dr. Sen sir had said, I prefer to use many a times a lateral small window, open up and put in a plates. I can see the SI joint properly. I can reduce the length of the ilium, which is broken. Also the mediolateral displacement, as well as the anterior-posterior part. When I look at it closely in front of my vision, and I put in like a normal SI joint fixation, two plates, which are going at perpendicular acute angle to each other, holding the fracture. And if you see, the only trick out here is that this fracture or the upper plate, you have to ensure that it is going into the broken area as well, and not only into the fixed or the posterior part of ilium, which is already intact with the sacrum. And then on the iliac crest, to ensure the top, we have also put in one screw, which is holding the broken iliac bone where the iliolumbar ligament comes, and it is holding it with the posterior column. And that in my hands, I always feel that if it is type 1 or type 2 Day's classification, where it is more anterior than posterior, my iliosacral screw, I'm not very sure where exactly they are going, because we are not putting in the plates as Carlos has said. I put in through a single screw, so that might be going through the fracture side. So this always helps me in supine position, getting an accurate reduction, and I can see in the image also how my reduction goes, both the bony as well as the joint dislocation part. And then as regularly we do, we have put it in the reduction part with tractions. If we could get it, we were able to get it problem with easily in a percutaneous fashion with some pins and the joysticks which we use. I normally use a picador like an iliosacral, like a C-clamp positioning where we put in, I put in the picador out there and give traction. And if it is reducing, we put in the guide wires. And we have put in the 2 guide wires and the screws, simple screws for the SI joint dislocation here. Regarding the interior fixation, once we have done that, we can see in all the 3 views that yes, the screws are going not into the neural foramina of both the opposite and the medial or the left or the right sides. Many a times I do not fix the interior portions when there are bilateral or even a pubic rami fracture. But this, if you see, is a very highly unstable pelvis which has got fractured, and ligamentous disruptions are there on both the sides, both the hemipelvises. So I feel it is imperative to fix the interior here, as was told by Professor Carlos. And I just went about holding them with small screws, and just giving a small incision and reducing that and putting in the screws. So this is the fixation which I could get. My intention was to add some anterior stability, so the smaller screws were put. I didn't want to be a perfect going into a long screws, because I thought that maybe this amount of fixation is going to help me. This was his initial comments or initial things, immediate post-ops, and we were able to get, this is his final when it was more or less in a acute, in a reduced position, and when he had come to us for follow-up. So I think that we have tried to fix up all the pelvis on all the sides. My question is regarding the rehab process. When we have such cases where both the hemipelvises are involved, how do we make these patients rehab? Because do we do in-bed mobilization and a wheelchair mobilization, or we can go about allowing them to put weight bearing within first 3 to 4 weeks? Comments, please.
At least 4 to 6 weeks, we allow in-bed mobilization. Being bilateral, the only thing we are scared is our patients don't listen and start, unduly bearing weight. There are chances that the screw might break. So in such case, probably I might add S2 also. That is number 1. But yes, toe touch is only after 6 weeks. We are not very confident of our patients' behavior with the way we tell them.
Right. Okay, so I think I'll finish it here. Yeah.
Just one comment. I am extremely aggressive in terms of surgical indication, but very cautious, very conservative in terms of early rehabilitation. I do not think that you need to win an hour to put the patient to work next day, because in several cases, this is just a claim to complications. For instance, if your screws have a trajectory that is, you use your screw as reduction tools, because the screw is approximating the hemipelvis, but the trajectory of your screw is not against vertical shear forces. For any reason, I try to avoid early weight bearing. And when I say early weight bearing, I consider also being sitting at 90 degrees, because this is weight bearing. I try to tell my patient, if for any reason I'm not satisfied with the quality of the bone in terms of the fracture pattern and the instability created by the fracture pattern, you have to be the first 4 weeks just in bed, 45 degrees, waiting for the soft tissue callus formation, like the fibrous callus formation, and then 90 degrees in a wheelchair until fracture healing. By doing this, my percentage of SI joint screw breakage is almost 0. But I have friends in the United States that send the patient to walk with SI screw, and they have a lot of breakage of the SI screw. They were not conceived to be working against vertical shear forces. And then the same happened with the 3.5 screw and the plate of the crescent fracture. But maybe if because I'm a coward, I assume that. But I don't like to deal with breakage of implants and secondary displacement.
Carlos, can I ask one more question? If there is a sacrum fracture where you have done a fully threaded screw, vis-a-vis a sacroiliac disruption where you had a compression as a fracture and you have put a iliosacral screw, vis-a-vis a sacroiliac dislocation where you have got a fixation with the iliosacral screw. Because in a sacroiliac dislocation, you are having a compression as a force of stabilization. But for a rehabilitation,
yeah, if I have a sacral fracture and I'm going to be using a screw, I defer the rehabilitation. But the other possibility, I increase stability by the use of a tension band.
Yes.
If you have a comminuted fracture, literature and many surgeons says do not compress. But I learned from experience that I prefer to compress a sacral fracture. It's like telling someone else how to kiss a lady. This is not a science, this is not a technique, it's an art. You have to feel, you have the perception of how strong is your screw holding, and in doubt for fracture or sacral fracture or dislocation, use a tension band. Because tension band is going to be holding both hemipelvis proximally. It's going to be avoiding, because something, it is very difficult to hear from speakers, the deformity and the movement created in rotation in the lateral plane. You know, when one hemipelvis do like this. So I've seen many surgeons using one screw for SI joint or for sacral fracture. I sometimes, because if the bone is very soft, it's a female and it's aging person, I try to engage one thread of one screw with the thread of the other in order to create a block. And if performing that, I'm afraid of the quality stability, do not hesitate in using a tension band, or if you have the surgical skills or money in your pocket, spinal pelvic instrumentation. In my country, the Spedium by synthesis at least 10 times more expensive than the 4.5 recomplete.
Certainly. Thank you.
Shall we proceed to the next speaker?
Yes.
If there are no more questions. Pranav Shah,
Yes.
Yes, sir.
I think you are the next speaker. Please go ahead.
I think Tirkha sir has completed all the aspect of crescent fracture, which was earlier we were discussing to be covered by the talks. And
Yeah, exactly. You told me to present the same case which was there with the lecture, so I
Yes.
converted that into the talk,
Yes, yes.
into a case
So,
presentation.
because crescent is many times confusion in the approach and fixation techniques.
Thank you.
Yes. Okay, Pranav sir.
Okay, thank you. This is a train accident victim. She shifted from a district hospital about 100 kilometers away. This is how she has come in our emergency room. She is a female, 42 years old. Train accident, she fell while alighting the train and she was trapped between the platform and the train. It is about 8 hours since injury. In ER, her pulse is 124, BP is slightly low, 88 systolic. She is conscious oriented but very anxious. And in form of primary treatment, she has received a LS belt, a BK slab on the ankle injury, and IV fluids via a single IV line. some antibiotic and analgesic. So that's what has happened. Now, what primary treatment to do before shifting? This is one thing I wanted to highlight. I had made it interactive, but because we are in, lot of time is less, so I'll just stick to the important points. So this patient was then primarily resuscitated by us. Her shock was managed with 2 IV lines, thick bore, 18 gauge, 16 gauge. Blood products and crystalloids were given. After stability, her CT scan was done. Her focused abdominal ultrasound was negative for abdominal injuries. Her X-ray chest and cervical spine X-rays were normal. She was catheterized. There was no blood at perineum and there was no hematuria. 150 ml urine she passed. And on regular reassessment, we found that she was responding well to the the management of hemorrhagic shock. So we gave her a binder and then we took her for CT scan. This is a CT scan. If you can see over here, she is having a bilateral posterior arch injury, as you can very well see in both these views. And this is her 3D CT scan. She's showing a right sacrum alar fracture and left SI joint fracture dislocation, which is a crescent fracture as discussed by Dr. Trikha. This is our 3D CT scan. I would request one person to comment if anything other than what is shown is to be highlighted. Dr. Srinivas, may I have you to comment? So this is the diagnosis that we are seeing. Do you want to add anything to this?
I think he's not connected.
He's not connected. In that case, yeah, anybody, Doctor?
I think neurological deficit is a very big possibility here on the right side because of the compression of the sacral ala around the foramina.
Yes, you are right. Absolutely right. She has right EHL-EDL weakness, and left side we could not assess very well, but yes, left side he was able to move the toes. She had ankle fracture dislocation, so we could not assess very well. But right side, she has EHL-EDL weakness. Yes.
Look at the soft tissues as well. Posterior injuries are there, sacral injuries. Both sides, railway platform injury. Very likely that she has posterior problems of the skin.
Yes.
That also needs.
Yes. So this is the 3D CT now of the sacrum. So it is more of a transforaminal injury now, and you can see so many impacted fragments going into the foramina. And we can also see that it's a dysmorphic sacrum, something that Dr. Paul Romans was highlighting when he was talking about trans-iliac bar. So this is a dysmorphic sacrum, right-sided. It is a compression or impaction injury with so many comminuted fragments going into the foramen. And you can see now, question to both the senior faculties, including Dr. Carlos, anybody can answer. Would you want to do an MRI in this patient? If MRI, what study you will request? Do you want to do decompression in this patient? And what approach would you use for if you want to do decompression? Let us start with Dr. Carlos.
MRI is a good idea if the patient is able to go into the gantry. If for any reason they have metallic things around him and you cannot put the patient in the gantry, you cannot use it. But if you have a good technician, you can recognize the morphology of the roots and you can tell if the roots are damaged or not. This is about MRI. About decompression, if the patient has such a comminution, it is not a bad idea to think in decompression. But in my experience, those patients who arrive on acute basis, as soon as you restore the anatomy of the pelvis, the amount of spontaneous recovery is very high. However, if you are sure that the indication for the decompression.
Would you consider decompression in acute phase? Like the first surgery that we have to do in this patient is pelvic stabilization. Would you add a decompression with stabilization?
If the patient has a clinical condition that allows me to think in decompression, yes. If the patient is severely damaged and the patient has bilateral chest tube or have a head injury or abdominal injury, I'm not going to attempt the decompression because I'm going to risk the life of the patient. And I'm not going to be sure if my decompression did work or not, because as I said, many patients recover spontaneously as soon as you restore the anatomy. You decompress the anatomy if you open the pelvis and you decompress the foramina. However, if you are in the field of the decompressors, yeah, you can fix, you can bypass the fracture line by spinopelvic instrumentation. You open the back and remove the pieces of bone of the foramina. And the literature is not extremely clear. At least the literature I did read, especially from Tim Poleman, at the end, the recovery is not predictable, and the amount of satisfactory result is not perfect. So finally, because I've done the decompression in those who were absolutely paralyzed and with no sensation, and what I found is all the roots were destroyed. So the decompression only did create much infection rate. So it depends where you work. You are working in a well-established place with all the resources. Yes, if you are in a limited environment, think in referring the patient to someone else. If you cannot refer the patient and you don't have experience in decompression, this is the kind of procedure you must not perform.
So what approach would you use to decompress? Because here you can see all the comminution is in the front anteriorly, and most of the times we go prone position and decompress from behind. So do you think we'll be able to adequately decompress the root all the way to the anterior part of the sacral foramina?
You can reach L5 very easily. It's not so easy to reach S1 from anterior. As soon as you want to go to S2, you are going to be dealing with the artery and the rectum because you are in the small pelvis. So I don't think it is very easy to work at this level unless you perform the Judith osteotomy of the pelvis. Judith has described a vertical osteotomy anterior to the SI joint for the surgery of tumor, and then you open the pelvis, you open the posterior component of your osteotomy like a window. And this is the only way, as I know, to go very, very deeply in the pelvis without working in a funnel, because otherwise, if you are performing a first window approach, you cannot reach all the fracture lines. The only way to reach a fracture line is by the back, or performing this kind of osteotomy, which is, it's a battery, because you have to split the gluteus maximus, you need to do the osteotomy of the iliacus. And if I'm going to do decompression, probably I will do it by the back, or if I'm going to do a decompression at the front, I'm going to reach only L5 S1 and not further without any risk. Because you have risking also the sexual capacity if it's a male because of the damage of the nerves which are regulated sexual function.
So this lady, Carlos, she has only EHL ideal weakness on the right side and some sort of neuralgic pain on right side, but other than that, she doesn't have any significant neurological deficit. Another opinion from somebody like Dr. Sen or Dr. Trikha, if you have had any experience of primary decompression in these kind of cases.
Yes, I have done few decompressions, and for me, one thing is important. It is the distraction first, which actually decompresses. So once you distract the compression area, automatically the fragments are likely to leave a space. And posteriorly, you have done the laminotomy, you have done the de-roofing. You are able to see the posterior side. I have no experience going anteriorly. I have done from the posterior side only. And once you have distracted it, you tend to get back the space for the fragments to get back to their own position, and the nerves are relatively free, and there with minimum manipulation you can get. I have done some with the neurosurgeon also, where we could really trace the nerve anteriorly from the back side. I'll restrict to that level only. I will not go more than that.
But then in that case, you will go from the posterior side,
yes,
right?
Absolutely.
And you by distraction, you mean that distraction between the two iliac crests,
yes,
so that you want to attain the width of the sacrum.
Exactly, because that will actually bring the sacrum foraminal. Actually, that is a decompression. I'll achieve that way, which will be helped by manipulation and by using those nerve roots and all that.
So in that case, sir, your first approach would be taking the patient in prone and going for a decompression as well as some sort of a trans-iliac, transsacral fixation from behind, right?
Yes, yes, exactly.
Okay, fantastic.
And in
So
that
that is
case,
one.
I'll be using those screws across the sciatic buttress area, which will help me in distracting also.
Yes. So it will be almost a lumbopelvic fixation on one side, another
Yes.
side, distracting the two and trying to get between.
Yes.
Yes.
Exactly.
So in that case, that will even take care of the other sided crescent fracture. Also, you can manage in the prone position.
Yes.
So that is one very good way of approaching this, doing it in prone position. Now, I mean, we have all the backup in our hospital. We have neurosurgeons and everybody, but they were of the opinion that this patient, as Carlos has very rightly highlighted, is going to be very difficult to decompress the front part. And they said that it's better to just manage the instability, stabilize the pelvis. Let us watch the patient after a few weeks. And if it is required, then we will consider decompression later on. So this was that patient's condition. As Dr. Trika had highlighted, the patients have a lot of soft tissue injuries when they are entrapped between the train and the platform. This is a right-sided wound where you can see all the fat necrosis is just coming out as soon as you press over there. So she had bad soft tissues and she was obese patient with this kind of condition. So I have now in this situation, how would you like to stabilize? How would you like to reduce? Whether we will open or not, and is fixator as a primary treatment enough or not? So yes, no, yes, no. Let me ask one by one. Let's ask first Dr. Srinivas. Dr. Srinivas, how would you like to stabilize this patient? Bony wise, are you here? He's not here.
Yeah.
Yes, Dr. Kishore, how would you like to stabilize this patient?
I will put external fixator. Sorry, I will first prone this and distract as mentioned by Dr. Sen. Then in the prone position, I'll put a fixator looking at this condition and
Prone position fixator means you are talking about
no. First,
okay, you stabilize in the prone from for posterior elements and then you make it supine and then put to fixator. That is what you are saying.
Yes, yes.
Okay, okay, fine. Dr. Vivek Trika, would you prefer to do this patient in prone position?
No, first of all, for me, I'll do minimal fixation, which is possible from the anterior side, and try to take care of the morale level. This is going to create havoc. This is going to really create havoc. It is railway platform injury. You wait for 7 days and then see the skin condition. I can guarantee you the entire skin on the back is going to cause problems and you will have got nothing. The only issue or only thing is you may put in a screw, iliosacral screw, just as a temporizing measure to stabilize the pelvis on the back side. And then the crescent and other things you can put in from a supraacetabular fixator. I'll remain there and concentrate all my fixations and all my energy on the soft tissue after that.
Yes, yes, very, very nice, important point highlighted by Dr. Trika. So it is a soft tissue many times which dictates how we go ahead. So I think all of us will agree that there is no point going for open reduction and going for extensive approaches in this patient because the skin condition can go bad to worse. So this is what I have done, put skeletal tractions on both sides, put the patient on traction peroperatively. This is the left side, the traction has helped to get axial alignment, but still there is a little gap at the SI joint, which has been managed with sort of an ST pin, and that gap is corrected. Multiple wires were passed with that well-reduced position, and then screws were passed. As Dr. Trika has said that many times we are not very sure whether these screws are going through the fracture or not. So even an LC2 screw was passed to stabilize this crescent so that that crescent is now one piece and then the screws can have a better hold. So this is the treatment done on left side, and then the patient was put on a fixator so that I could get some amount of distraction, which Dr. Sen had highlighted, so that I can get a little bit of reduction of that right-sided sacrum fracture. Since the patient has sacral dysmorphism, I will not be able to get many screws on the S1. I may get 1 or 2 screws. So I have done all my left-sided fixation in S2 segment and left the S1 segment for the right-sided. This is what I have achieved after distracting and putting 2 fully threaded screws on right side. Now, what for the anterior arch? We already have the fixator, so we have retained the fixator for some time. As Dr. Trika said, we watched for the soft tissues. We have put this drainage, and we are doing the dressing. Fortunately, that soft tissues over a period of time healed, settled down. This is the post-operative X-ray of that patient. 2 screws on left, 2 screws on right, and external fixator plus 1 LC2 screw. Though it is not a perfect anatomic reduction, but I think it is good enough to stabilize the patient. Any comments on this, Dr. Kale?
Sorry, I didn't get your question.
Yeah, any comments on this final fixation? Would you want to improve in any way, or you are happy with whatever is achieved?
Looks quite good with her, I mean,
reasonable
suspected
and acceptable.
moral level type of lesion.
Yeah.
But I think you would have had to do at least 1 or 2 deployments of that moral level lesion.
Yeah, we have done 2 times, just wash out, and it has fortunately settled down. It has not got infected. It was not a huge moral level lesion. It was more of a fat necrosis, but still over a period of time, it has settled down. So that has not bothered us. This patient was discharged on the, I think on 11th or 12th post-operative day. She was sent home with stable hemodynamic condition and continuing dressing at home. She came back to me at 4.5 months after being discharged. She shifted to Hyderabad. My friend Dr. Srinivas Kasa took care of her over there. Her healing was relatively uneventful. She started walking by 2 months. She started full weight bearing walking by 3 months. She came back to me at 4.5 months with this condition. She's otherwise okay, but only the EHL EDL has not completely improved, and she still has pain and paresthesia on the right side. So now again, the question that arises in my mind, and I'm sharing with you, whether we are justified to go for any sort of neurological intervention at this point of time. Just one comment from Dr. Sen.
My perception is that if that damage has already been there for 4 months or 5 months, probably, I don't know, because it was a compression injury, and that the fragments might still be there, but the injury which is caused right now might and might not be. So there are 2 problems with when we have got the pelvic injury along with the neurological damage. There are some traction injuries, just like a vertical shear injuries, where actually you cannot do anything because there are traction injuries and you can't get it. But in a compression injuries, there is a definitive element of a bony compression in the foramina. And if that is done, the easiest is at the time when it is acutely done, and probably we can have a better outcome. But if it is late by 5 months, I did have a case where after 2 months, probably we did it and it recovered. But 4 or 5 months, probably staying in that kind of a compression, I doubt about whether it will be successful. But depending upon the disability of the patient, I think there is no harm in doing it.
Sir, literature says that primary nerve injuries that you have in sacral fractures, they usually, you have to warn the patient that they may not get back the power.
Yes.
Yeah, my only concern in this,
it is a big compression over the nerve, which is important. I'm sorry.
Yes. Yes, you are right, sir. I absolutely agree with you. But my only concern in this case was that so much of all the compression or the elements were all anterior. So how we would, even our neurosurgeons were like, how will we reach over there from behind? It's very difficult. We can decompress from behind, but what can we do in the front? So even Dr. Carlos has said that reaching S2 level, S2 foramina would have been almost impossible. Reaching S1 could have been managed somehow. So I think initially, and considering the patient's overall hemodynamic condition, we were thinking of minimal invasive surgeries and try to minimize the complications. So this patient at 4.5 months with EHL EDL improving only pain and paresthesia. Again, I suggested that you can undergo a surgery for this, but we are not sure whether it's going to help you or not. She opted out of it. And at 2 years, she came again. That time I got a chance to do her MRI scan because I wanted to still see whether the neurological aspect is something that we can manage. So this was her MRI, which shows that almost the cord and everything looks all okay. This is the certain cuts they have taken for the L5 root, but even the radiologist was inconclusive about the MRI, especially because of the implants and implant artifacts. We did a EMG NCV which showed partial denervation of L5S1, but they could not localize whether it was at the level of root or whether it was at the level of trunk. So unfortunately, even at the end of all these investigations, we were not sure whether we can do anything for this patient. Anything else that we could have investigated, or any other idea of investigating such a patient with neurological injury?
I think I'm very
Yeah.
passive about these injuries because we do not have a very good evidence of having successfully done all these injuries. So that is my perspective, is if it is possible, the skin condition permits, everything permits, probably the primary decompression is the best.
Yeah, I think within first 3 weeks is the best thing to do, right?
Yes.
Yes. Okay. So this is an
I
excellent. Yes,
have a small piece of advice, is that the first you can, at that moment you can remove the implants, and then you can obtain a much better MRI.
Yes.
But then you can do an injection similar to the injection you perform when the patient has a lumbar disc herniation. You can do the injection of the corticoid and anesthetic into the root in order to distinguish in between the inflammation and entrapment of the root due to the scar tissue. What I do is I put the patient prone, then I try to localize S1 foramen, and then I put my needle in S1 from the back to the front. I check it with the CR. Usually radiologists who are able to perform the injection for this herniation, they do not attempt to do this. And then I do my injection in the foramen. And the second injection, I go with my needle on top of the sacrum with the trajectory of the sacral slope and try to finish where I imagine is L5. And I do an injection in this point. Several times, I cannot say it's a recovery, but it's an improvement of the symptoms of the patient. And some surgeons, they do release of the root on late basis. I have done the release of L5 in the front, and then it is not very easy because I need to remove not only scar tissue, but also bone formation, especially in the sacral fracture, if there is a gap or a step. When you try to remove it and the step is displaced, you can find that the root is stretched, and then you can create a notch while you are releasing the root. And by doing that, you think you have done a good job, and the results are random. So I'm not so sure if it is a little bit late for that kind of release. I've done it twice. That means in statistical terms, nothing. And the patient after that, well, it's a little bit better, but I'm not so sure this is a placebo effect of being operated by your surgeon. And if you have a good relationship, they say they don't want to make you feel unhappy, and they say they did improve. But this is one possibility, because many times the root is not entrapped into the sacrum, which is what you think could be very helpful by the decompression. It is entrapped in the front due to the scar tissue and the bone formation. Because I've done the surgery with a neurosurgeon or a spinal surgeon, they release everything in the back, but what they see in the back is very little, because mostly L5 is entrapped in the front, while it has already exited the top of the sacrum. In fact, there is a clinical description of something like the carpal tunnel syndrome, that is the entrapment of L5 in the dorsal aspect of the sacrum due to variants, anatomical variants of the ligaments. So if you do this and you release everything, maybe it can improve, but I recommend to do it carefully because you can damage the already small recovery of the radicular activity.
Yeah, I think, but the injection is a very good idea. We can try that, and we can at least assure that it's not in the sacral foramina. Yeah, so coming back to our story, this is her X-ray at 2 years, which shows that almost all the fractures have healed. And this is her function at 2 years. So she's able to sit the way she wants. She's able to do single leg stance both sides. This is her walking, her gait. There is a slight limp. Other than that, she doesn't have much of a problem. And as I said, it's very difficult to convince a patient when we are ourselves not convinced about the outcome of surgery. So I was not actually able to convince her whether we should go for a decompression or not. So she has just pushed it to a later date. My now last two questions is whether implant removal should be done. And I think Carlos has answered it. Yes, implant removal can be done to have a better imaging in form of MRI scan. And nowadays, these MRI scans are coming with new software which highlights the nerves. So I think when we get that, it's going to be more exciting. Anybody aware of it or anybody already using it?
Yeah, we have a software. We have to ask for a special technique that you can trace the roots. So that's the reason I said hardware removal. There is another reason. Sometimes what I have done when the screw is very near the position of the root, I profit of cannulated the screw and I release corticosteroids through the hole of the screw. After removal of the screw, you can use it and then you can put your injection very near where the root is. This is also another trick. And in your case, she is doing so well. So what we use sometimes is some chemicals in order to diminish. I don't know the name in English, but in Spanish the name is pregabalina.
We use it. Yeah.
Yeah, we have been giving it to her. She has been using it judiciously as and when required.
And it is improving a lot the symptomatology of the patient. And finally, this is something you can say everywhere. Try to find an interesting activity for your patient. Because we know, and I am telling you this from my own experience as a patient, you have to train your patient to develop affective indifference to the pain. That means try to move the pain from the cortex of your brain into a subcortical level. The pain is going to continue in place, but as soon as you focus your attention in something different, you can live with the pain in a way which is less anxiety to you. And finally, there is some psychiatric medication, antidepressive medication, that helps a lot to manage this situation.
Okay. Yes, so that's the end of it. Thank you, everybody, for your patient listening.
Yes, so there is one case which is related to all these nerve injury and delayed cases. So should we move to that case or we'll close it because it is my presentation?
I think it's quite late now.
Okay, so we'll close the session. Kale sir.
So we must thank Carlos for his time and the kind of a...
Pranav sir, just one thing. What is the status of the sural nerves in that case?
Sural nerve is fine.
Okay,
Patient has ankle injury on the other side.
So can I just shortly present my case because it is more related to that scenario with 5 minutes only.
Okay, sure.
So this is so is it visible, sir?
Quite okay.
Okay, so this is a young male presented after 3 weeks with this injury. So I will not waste much time with this classification because there is already this is the axial cord. So you can see this left side SI joint has been disrupted. So it is a mixed type of FPC and both LC injury. Even the L5 transverse process is broken. So I will place it in between LC3 and vertical shear injury, as we have discussed earlier. So yes, this was actually the topic which was earlier planning to be taken by Pranav Shah, Dr. Pranav Shah, and this is the zone where actually the EO classification, tile classification, and Young Burgess classification. There is a gray zone between the defining stable fracture and unstable fracture. So this is how I fixed. I released the soft tissue from the SI joint, then fixed in this way. And the next post-op day, I found this no dorsiflexion of the toe, ankle dorsiflexion was minimal, and sensation was intact. The only thing that I have not examined the patient pre-operatively adequately, so I can't comment whether it is due to the surgery itself or it was associated before, because if you can see the proximal plate or the distal plate, it is too medial. The two screws are on the sacrum. So I have retracted more, and this happened due to the exchange of Farabeau clamp. When I compressed this plate, actually went medial, more medial. So okay, you can see this SI joint has been reduced. Yes, this is the 3-month follow-up. This one thing I want to highlight, that with 3-month follow-up, he has the gluteal lurch. You can say the abductor weakness. He can do a single leg stance on the healthy side, but not unable to do on the fracture side. So then I did a MRI, and the MRI said that there was edema in the root region. So then I went through the literature, and there are 65 cases have been reported till date, and most of the recoveries are within 1 year. After 1 year, there is no recovery. So they have done a EMG study and this NCB studies, and they have found that the sural nerve is an important indicator for the prognosis. If the sural nerve is involved, then the injury is most likely the post plexus, and if the sural nerve is not involved, it is most likely the pre-plexus, and it is a good indicator of the prognosis. So you can see the sural nerve, most of the sural nerve injury, there are unassisted gait. They have developed the unassisted gait. So in conclusion, they tell that lumbosacral plexopathy after pelvic trauma is a characteristic lesion. It is commonly associated with the lumbar plexor injury that rarely occur in isolation. And sciatic neuropathy is seen in acetabular fracture, but not in sacroiliac disruption or pelvic fracture. And gait outcome is predicted by electrodiagnostic data. Gait outcome is worse in patient with sciatic neuropathy than the lumbosacral plexus injury. So this is after the 6th month. He sent me the video. Then, okay. So this is the video that he sent today only. So it has recovered completely. So you cannot notice any limp like that, which was present earlier. So it was a traction injury, as rightly said by Professor Sen. It recovers well. So that's from here, sir. Yes. So in short, I just. So any comments, sir?
That was expectable as a good result, because the patient didn't have a complete paralysis from the very beginning.
Yes.
So when you have a partial paralysis of
Yes.
the same innervation region, that means you can dorsiflex partially the ankle, but not the toe, you can expect a recovery. And usually, if the patient has good sensation and partial motor recovery, you can expect with the time a much better motor situation.
Yes.
So for me, the only nightmare is a complete paralysis of both branches of the sciatic nerve.
Yes.
Because if the plantar sensation and motor activity is complete and you have a paralysis of the dorsiflexion, I go to sleep, and it wasn't created by myself. I go to sleep without any trouble because I know that there is cross innervation first, and second, if you have a good muscle on the plantar part of your foot, you can do a transfer later on and recover a good dorsiflexion by the tibialis posterior into tibialis anterior transplantation.
Okay.
I mean, so you have this second opportunity.
Yes.
And we have done several times this kind of rescue. And those patients who after 1 year haven't recovered a good dorsiflexion and they have good plantar flexion, we transfer the tibialis posterior into the tibialis anterior position. It works wonderfully.
Yes. So we'll conclude, sir, now. So on behalf of Orissa Orthopedic Association, I heartily thankful to our overseas faculty, Professor Romans, Professor Carlos, and along with our Indian faculty, Professor Sen, Professor Dhaval Desai, and Srinivas Kasa sir, Dr. Pranav sir, and Dr. Kale sir. So I will thankful to our ortho team coordinator, Dr. Osak Syam and Samsuludda. Dr. Samsoloda, and not the least, I am very much thankful to my association, Odisha Orthopedic Association, for which I am able to do this event. So thank you. We'll see again in future, sir. Have a good day. Yes.
Right.
So any final message to conclude from Sen sir?
Yeah, no, this has been wonderful, and I appreciate Kishore to have taken such an active stand and really doing something good, and especially inviting Professor Romans and Carlos especially. I'm very happy because we are able to see something which you don't see otherwise.
Yes.
And that is the biggest thing, because routine things we are always talking about, but when we have a problem which is similar to our country and which is probably many times in our country, especially the pelvic malunion, non-unions, and we have a lot of, so there is a lot of relief. So both the topics, both by Professor Romans also, is something which is coming up, we don't know, and both this problem which is rampant, but we don't know how to do it. So I think they were wonderful speakers, and with their wonderful experience, we have been able to get a lot. And the credit definitely goes to Kishore for arranging everything. I think
because once we are not able to do these type of cases. Once we see that after down the line 4 or 5 years, or like, so that we can start at least.
yes, surely, sir. I hope that goes well. Yes. So Dinesh Kaleji.
Good day, Dr. Carlos.
Dr. Carlos, once again, it was amazing.
Yes.
Thank you very much. Thank you.
So
It was a real pleasure for me share this morning, for me this afternoon, for you, with all of you. And so excuse me if I was chatting too much, because in between friends, this is what I try to do, explain what I think.
Sir, if you would have gone the whole length for 3 hours, still we would have just kept watching. It was absolutely amazing.
Actually, we caught all the 4 lectures to listening only.
Okay. Okay, then. Thank you.
Okay, then. All of you.
Bye,
good night.
Sir.
Carlos,
Good
bye-bye.
night, Carlos, sir.
Bye-bye. Bye-bye. Thank you for everything.
Thank you.
Sleep well.
Yes, sir. Thank you.
Good day to you.
Thank you. Thank you.
See you sometime.
Sir.
See you.
Yeah. Okay.
Stay healthy.
Yeah. Let's hope.
Take care.
Okay.
Bye-bye.
Okay, sir. Bye, sir.
Bye.
Bye, sir. So see you on Monday, sir.